My name is Manoj Patel. I'm a basic scientist at the University of Virginia. I'm co-chairing this session with John Schreiber, who's going to talk, and he'll introduce himself, but he's a pediatric neurologist at the Children's Hospital in Washington, D.C. So what I wanted to say was Julianne unfortunately couldn't be here, but she did ask me to say a few words on her behalf, so I'll do that right now. She says, "My sincerest thanks to all the professionals for making our event a priority despite a packed AES schedule, for your interest in learning more about SCN8A mutations, and for your tireless support of our small but driven SCN8A community. Thank you to the families in attendance. I am humbled to know how many new families were able to attend this year's gathering, and hope that it brings us much magic and hope to your lives as it has to mine. I regret that I won't have the opportunity to meet you this year. Finally, I wanted to thank all 21 of the Acute Syndrome Foundation volunteers for their unending dedication and commitment to all those affected by SCN8A mutations. I am so honored to be part of this warm and supportive community. Have a wonderful time." So it goes without saying that we're going to miss Julianne today. So they've worked tirelessly to get this event together. So, but hopefully next year we'll see her again. So the schedule is very tight, as you can see. We've really packed it with the science because that's something that we thought was very important. So we are going to be very strict with timing. The folks who are going to be talking about the science, you know how long you've got, and within about 3 minutes of the end of the question time, if you see me stand up or you see John stand up, it means you really need to kind of get to the end of your presentation, if that's okay. So without any delay, I'm going to start off with a patient perspective, and that's Emma Johnson. So if Emma could come up now.
Hi, my name is Emma Johnston. I am 15 years old. I have SCN8A.
Thank you for coming.
Thank you for coming. And we want you to help
find a cure for us.
To help find a cure for us.
Have a nice night.
Have a nice night.
Thank you.
Thank you.
Thank you, Emma. We would like to welcome Michael Hammer and Alex Encinas for our registry update.
Thank you, Emma. That was a first. We got to hear from the kids. So I'm going to give this speech on behalf of the work that Alex has done, and it's filtered through maybe my way of looking at things a bit, but when she talks about it, she can filter it her way. But it's her work, and it's your data. It's the data that we have accumulated through the registry, which you all know about. And what am I doing this? Yes. Okay. All right. So the registry, for those of you who don't know, is a patient database of genetic variants and phenotypes that we've tailored to the needs of SCN8A kids and families. And it takes about an hour or so to get through if you're really ready to do it. And we're going to improve it this next year with by going to REDCap and hopefully streamlining the survey and making it easier to access. But what I'm going to talk about today is data that we collected over the last year. Actually, we finished collecting it last December. It was the 2017 database, and we've done some analyses of a particular topic that I want to share with you. I really want to explore the associations between the age of onset of seizures and the acquisition of developmental skills. I think it's a really important topic, and there's quite a good literature on this topic. We've known for a long time that there are associations between the age of onset of seizure, age of seizure onset, and developmental skills that have been acquired or not acquired. And so, excuse me, I'm trying to get back to this slide. So we know that this is a study from 1990 that shows IQ on this axis and age of onset of seizures. And you can see that a large majority of children in the lower IQ groupings had seizures that began before the age of 2. And we've known from other studies as well as this study that there's a lessening impact of the age of seizure onset on cognitive development. So basically, seizures are thought to have a strong impact on development, and it supports the idea of early intervention. And the reason for this is to propose that there are critical periods associated with normal brain development and seizures occurring at various times within the process. Here's in utero and birth and the first few months and years of life. This represents various processes such as synaptic pruning and dendrite and axonal refinement and the maturation of receptor and ion channels that are going on at different developmental stages in utero and post-birth and in the first few months of life. And so it's believed that seizures occurring at these times will have more severe effects the younger the child is, and as the child develops, the effects of these impacts of these changes can be long-lasting. And in fact, the very concept of epileptic encephalopathy is based on the fundamental concept that seizures themselves interfere with the mechanisms of learning and memory, and in a developing brain, actually impede acquisition of mature function during critical periods of development, such as I had just shown you. So going to the data that we've collected from our database, it's important to see that only 18% of parents report age-appropriate development, 78% some form of developmental delay. And when we look at the age of onset of seizures, we have this very interesting pattern where you have 20% of the children have a seizure in the first month, the neonatal period. And then there's another group that have a seizure somewhere in the 5 to 6 month range. And then there's a third group of children who have their first seizure later, 10 months or shortly thereafter. And there are children who have seizures many years later as well, occasionally. And so it was obvious that we had an interesting way, a handle from the literature to ask questions about what the association is between these different ages of onset and the associated developmental skills. So the main question I want to address tonight is there such a correlation in our data between seizure onset age and cognitive and behavioral development? Now, the way we are going to assess this is that embedded in our questionnaire, you may or may not realize there are 27 different questions about developmental skills. And so, excuse me, you can see there are 4 different categories in this Denver 2 developmental screening test that we've borrowed questions to ask about age of acquisition of adaptive skills, such as smiling and waiting and drinking from a cup, gross motor skills, which include head control, rollover, sitting. And what I'm showing on these bar charts is the age at which a typical child will acquire these skills. 90% of typical children will acquire these skills, and that will be our benchmark as we look to the data that we've collected. And then there's fine motor as well as language skills. And you can see reading is something that isn't generally acquired by typical kids until 70 months. Drawing a circle and running, these are things that are coming later in development. So this is what the data look like from our registry, and this is a plot that Alex made, in which you can see that the ages on this axis, the months, and then the 90% neurotypical line is up here, and you can see as SCN8A children get older, these are 27 different skills that I just showed you on the previous slide, and when they're actually acquired by children in our registry. And you can see the older the child is, the more delayed they are from that 90% developmental neurotypical line. And so what you can look at within this is that fine motor skills are typically about 4 months delayed, adaptive skills about 5 months delayed, gross motor skills 8 months, and language by 15 months. So there are differences within these different categories of developmental skills that are acquired at later and later ages, and that's what this curve is showing you. Now, we wanted to do, the first question was just taking all of the members of the registry participants who have had seizures, which turned out to be about 82 in this particular analysis, and we plotted the age of onset against the percent of those skills that have been acquired. So you can see the percent of the skills acquired here, and if they're too young to have acquired that particular skill, they're not included in the data set. So we control a bit for age, and then you can see that even though it's a weak correlation, there is a significant correlation between age of onset and developmental skill acquisition. But we also noticed that it's a weak correlation and there's a lot of variance, a lot of outliers, and we wanted to know what these outliers were about. And the first thing that occurred to us is perhaps there are other variants that these children have that could make them not respond in the same way as just having an 8A variant. And so when we went through the database and looked at what other variants were present in these children, when there was data for we found that there were 40 different variants in 34 of the 82 individuals. So this is striking that when we're thinking of each of us having an 8A variant, which very well may be the driving cause of the epilepsy, there are also other variants that people have, and these are known as variants of uncertain significance. And in this data set, I just took all the variants of uncertain significance that were reported in the genetic reports of our kids in the registry, and I just threw them into string, which is a way of showing how these different variants may interact. And sure enough, there were plenty of interactions among the variants that these children have. You can see there are 5 individuals with additional sodium channel variants, including SCN8A, SCN2A, a couple of SCN9As, and then there were 6 individuals with potassium channel variants, KCN3 and 4 and 2, etc. And so while these variants may be of uncertain significance or benign in a person who does not have an SCN8A variant, there could very well be interactions that are going on between the SCN8A and these other variants. So the very next thing we did was we removed these into 2 different groups. We subdivided them into the group of children without an additional variant, there were 49, and children with the additional variant we called SCN8A+, and there were 32. And you can see we lost the correlation in those that had an additional variant in addition to SCN8A, no longer an association between developmental skill acquisition and age of onset, and this correlation strengthened for those that had just a pure SCN8A. And of course, we don't know if there are other variants. It's only what's being reported in these genetic reports. So that was quite interesting. So then we wanted to know another question. We wanted to know if regression at the time seizures start would have anything to do with how well children developed, and could those who regress and don't regain skills, could they also contribute to some of the scatter in our correlation analysis? And what you could see is when we asked, did the child regress when seizures started, almost half said yes, and then about a quarter said no, and then about a quarter didn't quite know. So what we did was we divided the no's into a group, just calling them the no regression group, and we divided the yeses into regression without regaining skills and those that regressed and regained skills. And then we went back to look at our associations, and what you see is very interesting. Those that regressed did not regain skills. You can see our numbers are getting a bit small. We lost the correlation with onset age of seizures. But those that did not regress and those that regressed and gained skills kept that association. In fact, you can see, even though there's only 9 individuals and we don't achieve a 0.05 p, we're close. You can see this very clean pattern of onset age associated very nicely with developmental skill acquisition. So it seems as if we're sort of cleaning up the data in a sense by removing individuals that have additional mutations or that have regressed at the time of seizures. So just to summarize what I've told you so far, if we look at all the data, this is just a statistic that tells us how well the samples fit the line, the association, the correlation line. What you can see is that we have the SCN8A plus, where we lose some of that correlation. We have the SCN8 only, where we gain a bit of it back, and those that did not regress or regressed and gained skills have the greatest correlation with the age at seizure onset, and those that regressed and did not regain skills do not show any correlation with age of onset. So then we asked, it's clear that there are other factors involved other than age of onset of seizures. And so what we asked then, we also asked in our question is, are there delays prior to the onset of seizures? And you can see that a third of the participants said yes, there's a delay before onset of seizures. So clearly, seizure onset is not explaining everything about developmental skills. And we asked, is there a regression well after seizures start? And 31% said yes. So there are secondary regressions that occur well after seizures start. So these are giving us a clue that it's more complicated. There are many other things that could be correlated with developmental ability to develop. So what are the kinds of factors that have been previously implicated in cognitive outcome with early life seizures? And the main features that you can find in the literature are the underlying etiology of the epilepsy, which in our case we know, which is SCN8A, but we don't know really the pathophysiology. We don't know what the various things that are going on in the brain as seizures develop or after seizures develop. So seizures themselves, as we've been saying, but we've only been studying the age at onset. There are other characteristics of seizures that may be very predictive of how a child might develop, such as the seizure type, whether it's a myoclonic seizure or a tonic-clonic seizure, or the frequency or duration of the seizures. Those are other aspects of seizures that could be correlated with developmental skill acquisition. And we know that anti-epileptic drugs themselves have an effect on skill development. And it's been also shown that an abnormal EEG, in absence of onset age, has an effect on seizures, spikes and slow waves, etc. So these are all different ways that we can explore the data to see if any of these sort of features correlate with the developmental skills. And just to finish up, I wanted to show you one more thing. It seems that if we simplify our models of development, we can put our children into basically 4 different areas, 4 different patterns. And we've asked the registry folks and the Facebook group these kinds of questions and done surveys, and it seems that most of the children fit into one of these basic developmental patterns. If this is neurotypical development, we have some children who have very little development, don't acquire their first milestones even. And that's our pattern A. Pattern B is the opposite. Children who are doing quite well, we call it slow but steady. They're not quite keeping up with neurotypical development, but they're making steady progress as they get older. And then we have this other 2 patterns that have to do with later onset regressions that are not due to the onset of seizures. There's the C pattern where there is a triggering event of some sort. It could be a vaccination, it could be a change in diet, it could be just a different seizure type arising that causes the loss of skills. And we all know about that. We've seen it happen in our children. Most children in the pattern D will be able to respond and regain their skills after those secondary events, whatever they are. And where some children lose their skills and are not able to get back to where they previously were. And if we look at the frequencies of these different patterns in our data, you can see A, B, and C, and D are all fairly relatively equally common among our participants. But when we divide the group into those that have an SCN8A only versus those that have an SCN8A plus some other variant, you can see this enhances those in the group A, the ones that have very little development, whereas those that have just SCN8A have a more enhanced membership in pattern B, which is the slow but steady. So it looks very much like other variants are interacting with 8A to impede development. So I'll conclude now and just mention that there are multiple factors that that are associated with ability to develop, and that age-at seizure onset is only one of these factors. The correlation between development and age at seizure onset is weak with many outliers, and the correlation is lost when we consider children that regress at seizure onset or do not regain their skills. And secondly, additional variants add complexity, so that correlations with development is stronger when excluding patients with a variant at a second locus, and individuals with an additional variant tend to have more serious developmental delay, for example, in pattern A, as I showed you. So the things that we can explore in the future with data from the registry and just kind of thinking about how we might be looking at other kinds of markers or biomarkers of development, whether we can explore the particular mutation and whether it's a gain of function or loss of function, its prediction as to its how strong it is. We can look at in those that have in utero tremors, those that are delayed before their milestones, delayed milestones before seizures, those that may have an abnormal EEG. So that's the importance of collecting the data from you about your EEG report, from your EEG reports. Seizure characteristics such as type of seizure, and again, the EEG and the interictal spikes. And so that just sort of summarizes, and I take a quote from Alex. She sent me an email. I said, what do you think this all means? And she just said, the takeaway says that there's more going on. And so I just quoted her direct quote because it is Alex's project after all. So thank you again for your support to the Cute syndrome, the Wishes for Elliot, Xenon Pharmaceuticals have all helped us in various ways to develop the registry and the database. And especially I want to thank all of the children and all of the families who made this possible and contributed the data to our registry. Thank you very much.
Thank you very much. Now I'd like to welcome Dr. John Schreiber, who's going to discuss, you need to jump up too? Discuss his multidisciplinary SCN8A clinic. Thank you.
Thank you. It's the advantage of being tall. I can step up here. So thank you for having me to speak tonight. I'm very pleased to be here. This is always a great gathering, and each year it seems to grow. So I'll be talking about the multidisciplinary clinic for SCN8A that we had at Children's National last year. Many of you participated, and thank you for doing so. You all know what SCN8A related disorders can look like. There's mutations described that can result in intellectual disability. That's been known for a long time, and thanks to Dr. Hammer and others here in this room, we've discovered the impact that SCN8A can have in causing epilepsy and an epileptic encephalopathy. It also causes movement disorders. Dr. Gardella, who will be speaking next after dinner, actually wrote one of the first papers on that, describing a movement disorder that can be seen in SCN8A. The idea behind this clinic is this would be the basis for a natural history study, so we can have patients seen by multiple specialists at one site and determine what this phenotype actually looks like. This was a big collaboration, an effort from multiple different scientists, clinicians, and families, in part from this organization here, to identify some areas we wanted to focus on. The comorbidities that you all identified described by parents most commonly are constipation, low tone, movement disorders or ataxia, high pain tolerance, and sleep difficulties. That came from data from the registry from TCSF. And the top family priorities for research in 2016 to 2017 were new therapeutic approaches. We have lots of people in the room who are looking into that. Establishment of a medication regimen, a preferred medication regimen. Understanding clinical severity based on genotype, and determining the effects of SCN8A on EKG, on other cardiac measures, and then how that can translate to SUDEP. So going forward with that, we had a few aims for our clinic. One was to really get understand the clinical characteristics in full, understand the phenotypic spectrum of SCN8A related epilepsy. Number two, to collect blood samples. So we have peripheral blood mononuclear cells and DNA. We have PBMCs on patients and then DNA on first-degree relatives for future use for a biorepository. And number three, as part of another study I do, we collected a specialized echocardiogram that is able to detect very subtle myocardial injury. So we recruited patients with epilepsy due to mutations in SCN8A at Children's National Health System through family organizations including TCSF and SCN8A.net. We reviewed medical records. People sent us boxes of medical records or discs or flash drives with genetic testing, with imaging, with EEG results. And that was probably one of the hardest parts of the study, is kind of getting all this stuff. I think for the parents, that was probably the hardest part, is not even just coming here, but going to the hospitals and getting all those EEGs and the neuroimaging. They were seen by me, one of our movement disorder specialists, physiatrist, speech and language pathologist, cardiologist, and our neuropsychology team. As I mentioned, we collected blood, and we did speckle tracking echocardiography that I'll talk about in a second here. We also tried to make it an event, so this was meant to capitalize on the fact that AES was in DC last year, so we had several families coming in for that, and in concert with that, many agreed to come over and be seen by us at Children's National. So the reason for the echocardiogram, we know that mutations in SCN8A have direct effects on the heart, and there appears to be a very high risk for mortality, particularly from SUDEP in cases that we keep hearing about every week, every month. As part of a larger study, we've been doing this at Children's National for the past couple of years, a special kind of echocardiogram called speckle tracking echocardiography that measures cardiac strain. And strain is a measure of the contractility in the heart. It detects how these speckles, small dots that I'll show you in a second, in the myocardial wall move. And that can be a marker for very subtle myocardial injury that might not be evident on regular standard echocardiography. We've actually done this on patients with various forms of refractory epilepsy, and actually we just received a grant from the Dravet Syndrome Foundation to fund this study for the next couple of years, looking at patients with Dravet, other refractory epilepsies, and status epilepticus. So this is what it looks like. It's just, again, it's an echocardiogram. It's non-invasive. It's looking at these small speckles and how they move within the myocardium. And you can see that changes over time in systole and diastole. We have yet to analyze that, so that data is to come and will be forthcoming in the upcoming paper. This is just a depiction of how we collect and centrifuge peripheral blood mononuclear cells. There's many purposes for this. We have now banked these at Children's National and are storing them for future use. I think one of the really interesting things is that we can develop iPSCs from these PBMCs. So we enrolled 15 patients with SCN8A related epilepsy, some with SCN8A epileptic encephalopathy, some without the epileptic encephalopathy, along with first-degree relatives. The median age of the patients was 4 years, ranged anywhere from, actually this should be 1 year to 19 years now, and 6 were female. There were known or likely pathogenic mutations in 11, where the other 4 had variants of unknown significance, and you can see the characteristics there. Some of these variants were found to be inherited. One was found to be paternally inherited, another was de novo, and in another we could not determine inheritance. So the epilepsy phenotype, seizure onset, ranged anywhere from 1 day to 4 years old. The median age was 4 months, which goes along with the registry data. Seizure types varied, so some had generalized motor seizures, some had multifocal or focal seizures, and some had mixed seizure types. We actually had one who only had atypical absence seizures with a later onset. Status epilepticus was also a common problem. A third of them had episodes of status epilepticus, some very frequent status epilepticus being, prolonged seizures. We found that the clinical course was typically progressive. There was this sort of onset, which usually wasn't very abrupt at the very start, but then would actually get worse rather quickly. And most of the people that we saw were fairly stable by the time we saw them. That is probably biased because those are the kids that are going to be able to travel. That's certainly not true for everyone. So there's a spectrum of disease, as Dr. Hammer and others have shown, where some can be seizure-free. We found that it was more often in those who had normal development prior to seizure onset and better developmental outcomes overall, though our numbers are small. I'll get into this in a minute. The anti-seizure medications that were used were primarily those that targeted the voltage-gated sodium channel: oxcarbazepine, lamotrigine, carbamazepine, phenytoin. And 3 had seizures that were completely controlled for at least 6 months at the time we saw them on one of these medications, either alone or in combination. So it seemed to be that if seizures could be controlled, they were controlled with one of those medications or a combination of those medications. We also found that benzodiazepines were the next most frequently effective class of medications, particularly in those that had more refractory forms of epilepsy. That tended to be your next best option. As we know, levetiracetam did often result in worsening seizures for many folks, although we do find the occasional person who does seem to benefit from levetiracetam and still don't really understand why that is. This is just showing that in graphic form. So I grouped medications according to the sodium channel blockers here. There was actually 2 that seemed to worsen with oxcarbazepine, but most did do better, and some were seizure-free with the sodium channel blockers. Again, benzodiazepines were more often effective than not, whereas levetiracetam made it a lot worse or was ineffective except in 1. And then other medications, it was pretty variable, but we are struggling to find medications that might be more useful, more beneficial. This is each medication individually. You can see actually that people try a lot of things, right? So we have esficarbazepine, zonisamide, Fycompa, or perampanel, primidone, vagal nerve stimulator, prednisone, stiripentol, ethosuximide, and ralguzole, which is an ALS medication, which is not effective. On examination, we had 5 who had no communication, 8 who had some language delay, and 2 who had normal language. 11 were hypotonic, 4 were normal. As far as cerebellar or ambulation was concerned, 8 were ambulatory but had ataxia, 3 were non-ambulatory, and 4 had normal gait. And then 3 had overt movement disorders. Our movement disorder specialist is also analyzing the videos we have collected of patients to really see if we can get a better movement phenotype. our speech and language pathologist administered some scales and actually did spend a fair amount of time with these families and found, I think the take home from the coming slides here are that the oromotor problems, the feeding problems, the swallowing problems are probably a bit underappreciated, whereas the communication problem is quite evident and quite clear. But there's two scales here that she used. One is the eating and drinking ability classification system, and the other is the communication function classification system. And they're ways of grading 1 through 5, with 1 being the best and 5 being the worst, of how effective these people are at either feeding or communicating. I think what you'll find here is that these generally seem to correlate. So the patients who did better at communicating also did better at feeding. There were many patients who were not effective communicators, but who had no issues with swallow. But there was the occasional patient who was able to communicate some and had significant issues with their swallow function. So what we found actually is that many people were didn't have any kind of feeding precautions that were in place. And this is something, knowing what we know about mortality in epilepsy, this is really critical. One of the main things that can result in mortality and epilepsy-related deaths is pneumonia. So I think this is one take-home from this clinic that we need to make sure is addressed. We also administered the Vineland, which is a developmental scale, and found that people were sort of all over the board, depending on the realms you looked at tended to correlate. But this is each individual patient you see here, and they really run the gamut from very severely affected to normal. Normal being 100, above 70 is considered to be normal. 70 to 85 is borderline. But you can see that people kind of ran the board here. But some actually had what would be considered normal or only borderline abnormal development. I think Dr. Gardella is going to get into this a bit more, but neuroimaging and EEG. Neuroimaging was typically normal. 3 had mild to moderate cerebellar and or mild cerebral atrophy, and that seemed to be progressive. That developed over time. There were some other findings occasionally which did not seem to be found in any more than 1 or sometimes 2 patients. The initial EEG was often normal in the 6 out of 13 where we actually had that initial EEG report. Like I said, we're still working on getting all that raw EEG data, and whereas subsequent EEG showed generalized slowing, multifocal slowing, or interictal epileptiform discharges. This is one of our patients who had an MRI at 7 years, and again at 12 years, and you can see here some progression of the cerebellar atrophy. Okay, this goes over all the data from each individual patient. I've talked about this already, but the summary here will be on these slides. I'm not going to go into that too much more. So to conclude, this is the first report of a large series of patients with epilepsy seen in a single multidisciplinary clinic. The epilepsy phenotypes are variable. People have both focal, multifocal, and generalized forms of epilepsy, and some atypical absence epilepsy. Response to medication and development also vary, and they may correspond to the specific mutation to some degree. We did see some differences according to genotype. And this is hopefully will help to establish a basis for a larger natural history study, which is a critical step in developing more effective treatments overall. One other thing we'd like to do is to help to validate some of this data that Dr. Hammer's collecting in the registry, and I think that's another critical step of helping us to use all that information that you all have entered and that he and Alex have collected. Future directions, we want to enhance our EEG and MRI collection remotely, really look more closely at this EEG to see what we can glean from EEG data, both ictally and interictally. Do some longitudinal follow-up, determine how to really use our PBMCs and DNA what sort of functional assays we may want to perform, look at our echocardiogram data. I talked about validating the registry data, collect some more EEG and imaging, think about what outcome measures are important, and this can be some of the discussion tonight. Consider potential biomarkers for comorbidities or other secondary outcome measures we might want to look at, and then increase education and outreach, really get the message out about our treatment recommendations to clinicians who are there on the front lines, and improve access to people who need access to expert care to establish some of these clinical networks. So these are all the people I'd like to thank. There are more people as well, but Adrian Boombut, who's sitting back over there, has done a lot of the work to make this clinic happen. I want to thank him. Working with the IRB and doing all the logistical work behind the scenes, and a big team there at Children's National Medical Center. Also, Michael Hammer, who really has done a lot to support this work here and support the clinic and think through these ideas. And we also got we got some financial support from one of our families in their organization called Motivated for MAV, and logistical support from TCSF and Wishes for Elliot. And thanks to all of you for coming to participate.
I hope you all enjoyed your dinner. We're going to go ahead and get started up again. I'd like to welcome Dr. Elena Gardella to the stage.
Good evening, everybody. Thank you so much, organization, for having invited me tonight, for share our experience and research, share also the ideas and all the knowledge as possible. So I'm going to talk about what we do about SCN8A, and I'm a physician, so a clinical neurophysician, so we'll talk about patients. And we start collecting patients with SCN8A after the very first description, and we produced our first paper in 2015, and it was already clear at that time that probably it's the epilepsy, because we talked mainly epilepsy at that time related to SCN8A, was quite a spectrum of phenotype in terms of severity. The patients are not exactly identical. And now we are analyzing and collecting more than 200 patients, almost 250 right now, and 1/3 of them are not published so far, and it seems quite clear that the spectrum is quite wide, and it's composed from It's composed a minority of patients do not have epilepsy at all, and there are patients with severe degrees of epilepsy ranging from a very benign form to extreme severe epileptic encephalopathy. But the core of the manifestation is consistent with different contribution of these symptoms, which are composed by epilepsy, which is a core cardinal symptom in most of the patients, intellectual disability, motor symptoms, mainly dyskinesia and myoclonus, and the tremor is actually a cortical myoclonus in this patient, and is a key feature of the main of the patient, and autistic feature of the AGD. And these symptoms can combine in a different way, giving different phenotype and have different severity. And actually, considering that this is a spectrum, makes sense subdividing its subtypes. After in my optics, make a great sense, because focusing on the different subtypes, we can provide further speculation and insight. And we learn a lot, for example, analyzing the severe phenotype, which was the most represented so far, because there are many patients in the severe extreme of the phenotype we've actually diagnosed so far. And we just published a paper, and this is amazing how these patients are homogeneous in terms of symptoms onset. The onset is very early, about 4 months of life, and both the evolution, the electroclinical phenotype, I have no time to go into details, but in any case, they are extremely similar. They are a similar follow-up, a similar way to be treated with the therapy. The response to the therapy is not that good, unfortunately. But I will come back to this talking about the mortality, so I move to far away. And On the other end of the spectrum, there are the very severe phenotypes doing very badly, and we also have families with extremely mild phenotype. There are patients, normally families, having seizure during the first, second year of life, a few of them, a few clusters of seizure, and they do not need a chronic therapy. Then they grew up with this seizure. They are normally functioning, cognitive, perfectly intact, even clever in this family. And some of them, they are dyskinesia later on in their life. These patients are normal people having a seizure, not needing chronic therapy. They are extremely benign phenotype. A few of them, there are a few patients describing this. In between the two extremes of the spectrum, there are a big core of patients, and I'll bet this group will be increasing in the future because so many patients have been tested right now. And the patient with a milder phenotype, that means they are epilepsy, they are cognitive impairment in a milder degree, and there are some very discrete neurological symptoms, but not really severe. These patients are later age onset. The major onset is 7 months, but they can start up to 7 years of age having epilepsy, and they do not progress in severity, both in epilepsy and in neurological symptoms, the cognitive disability. So this patient seems to be quite stable and quite easy to treat. Normally, one half of them can be treated with a single anti-epileptic drug, and they respond pretty well normally. And also, these are patients not evolutive. So this is a quite heterogeneous phenotype, but are sharing a very benign trend normally. They can be sporadic, or we also some families, 6 families in our case. This is a paper which has been submitted, so I hope will be published in the next month. And we know also there are also patients not having epilepsy at all, but there are fewer of them so far because they are probably not tested, but there are patients described as having just epilepsy, just intellectual disability, or myoclonus or ataxia, but not epilepsy. So this is the background for what I just moved. It will take probably an hour to go a little bit more into details. I don't have time for this, but I will focus tonight on the topic which is I'm more passionate to in this period. It is the mortality in this patient. And I think we need the background, being aware that there are different subpopulation of patients with SCN8A mutation, which can have different risk factors for mortality. And it's not just, they're not just approach at one single condition. So we start the very first description of epilepsy with SCN8A mutation has been associated with SUDEP. So there is, from the very beginning, there's stipulated a link between SCN8A epilepsy and SUDEP. And we have the similarities with the patient with SCN8A and the Dravet syndrome, and we know that those patients, they are a high risk of SUDEP, and the risk is there are several studies of this. So this is another thing that supports the fact that this mutation can be linked to SUDEP. And we have the mouse model. So actually, these 3 things together, they show that there is a quite strong correlation between SCN8A and the risk of SUDEP. So far, it has been estimated the risk of SUDEP accounted for about 10% of the children of the patient with SCN8A mutation, which is extremely high. And it's also scaring, extremely scaring, because there are no correlation without the type of the mutation, the position of the mutation, the modulator of the mutation, that can give us an idea which kind of patient are at risk for SUDEP or not. This is the state of the art so far, but I'd like to put some positive insights in the new findings. I believe there are something nicer to talk about. For example, we are aware that patients with SCN8A mutation might be extremely different. So let's look into the phenotype and try to understand whether the discrimination of this phenotype can help us in understanding a little bit better which subgroup is first early mortality, and which kind of mortality we talk about. So first of all, the patient with not having epilepsy, just with behavioral movement disorder, they have been not reported to having had early mortality. There are few of them, but in any case, no sign of early mortality observed. In the group of patients with benign epilepsy, that means epilepsy they had in the first 2 years of life and not having an active epilepsy any longer, there is just one little girl who died at the age of 13, and she died because of cancer. So it's not, this death is not related to SCN8A. So we can say that nor the patient without epilepsy, nor the patient with benign, very benign epilepsy are at risk for early mortality so far. There are not that many, but in any case, no report. So there are probably only the patient with active epilepsy that have an increased risk of early mortality. But if you look inside these subgroups, so among the patient, we were collecting the data, was working on the severe phenotype. I was thinking, okay, this do not match with our knowledge about the incidence of the prevalence of the mortality which are reported so far. And actually, we recalculated the risk of mortality in this patient. And actually, the early mortality rate it became to be at about 4.5%, which is on half what it was computed before. And this patient can die in an age ranging from 60 months to 17 years. But most of them they died in early childhood. I come back to this. So we asked our PhD, computed also the incidence and the SUDEP rate, and the SUDEP rate seems to be lower than in Dravet syndrome, and this was probably overestimated before. But the most interesting, I think, to me, consideration came from the study we were going on at that time. It was the inspiration for this paper on mortality, was our work on the severe phenotype, which was extremely inspiring because we learned a lot. I learned a lot. So if you consider the two phenotypes, in the severe extreme, sorry, not too fast. In the severe extreme, the early mortality rate is 5.4%. There are 7 children out of under 28 they died before the age of 7, and which is still one also was considered the mortality rate before, which was 10, but it is quite high. In a milder epilepsy phenotype, that means the children having mild intellectual disability, a mild, well-treated epilepsy, and non or mild motor, impairment, the mortality rate is much lower. Is 1/2, is 2.8. Just 2 patients died early in this group. And this is the first point. So actually, also for counseling, it's important to give a message, because if you see a patient coming, for consultation, and say, okay, you have 10% risk of SUDEP, is one thing. If a patient coming and you have very benign epilepsy, or even a mild epilepsy, you can be much more optimistic, not saying the risk is 0, but it's totally another story. So I believe that this for counseling is extremely important. And then I approach quickly, but I am forced to be quick, but in any case, there are a lot to talk about the severe phenotype, to the children which are doing really, really badly. And we had, in this paper we published, we are a casuistic which is extremely homogeneous, so they are exactly identical actually. And among these 22 patients, 4 died. And they died very early in life. And we have but all of them, we reviewed all of them, they died for causes what ordered the SUDEP. So this early mortality is not related to SUDEP. 3 died for pulmonary infection, and it was consulted also at the hospital. And 1 died because of the seizure, which come more and more severe up to continuous status epilepticus, extremely refractory, which by definition is not SUDEP. So I will need to go a little bit more into detail of this phenotype. I try to give the most important point. I'm not saying that these patients do not have factor risk for SUDEP. They do have. Actually, they have very prolonged seizure. These seizures are mainly during sleep. They are vegetative symptoms. They can be extremely severe at the very beginning of the seizure. Some of these patients, they need resuscitation every time they have a cluster. So actually, it's quite scary, and they have frequent generalized tonic-clonic seizure. So there is a risk for this, but actually, for SUDEP. But actually, they die just when they have extremely worsening of the neurological condition, of the epilepsy condition. And actually, this is quite typical for this patient in a peculiar age. Actually, this is one little girl. It's a typical one. They are patient on a wheelchair. They have feeding tube. They are quite prominent hypotonia and tetraplegia at the same time. No, most of them, they do not have eye contact, which is progressive because they start having a good visual contact in the very first year of their life, and then with progression they become blind. And there are quite significant gastrointestinal symptoms, including unsafe feeding and reflux, and as I said, one half of them, they are PEG. Beside this, there's a sign of a sort of progressive disease of involution. They have a progressive acquired microcephaly and an atrophy of the brain. So actually, this is there are several MRI scans for a little child who died at the age of 26 months, and it was quite bad from the very beginning. But you see, this is the very first scan, and the second one, and the third one, and the last one at the age of 12 months. And you can see a progressive atrophy of the brain, really prominent in the anterior part, but also including the tract, because actually the occipital lobe are the most involved in the epilepsy process in this kind of patient. But in any case, you can see beside this patient has a trend in the progression of the neurological symptom, can be very stormy, from the age of 2 and about the age of 5, or 1.5 or the age of 5, they can have a very quick worsening in the global neurological condition, the condition. They have an involution, anatomical involution of the brain, and they have a extremely worsening in the epilepsy. All these things together, because of this, they become extremely fragile, and they can have, for example, a superinfection of being more prone to die because of causes that in most of cases are not SUDEP. So just to give an idea, this is a little complicated schema, but I put it on because I was thinking it was worth to show in any case. This is the schema I have in my mind for the trend in this subgroup patient. To have the patient they die, because the other patients do not die that often. This patient dying, they are an onset phase where they are in the age from 0 to the epilepsy onset. They are doing quite well, or most of them are almost normal children, or mildly. So they were born as normal children, which is important, and then epilepsy start, and can be a stormy, very stormy phase comprising from the age of 1.5 years to about the age of 5, roughly. And then there is a plateau, and this is a schema which I did roughly for the trend of the symptoms. There are both neurological symptoms and epilepsy. And this is the severity of the symptom for two patients in this group, for example. And you can see that they start doing almost well, no symptoms of a few of them. Then the epilepsy starts, and the symptoms becomes worse and worse. And then after a peculiar age, the critical age is between 5 and 8, they have an amelioration or a stabilization of the symptoms, which is what is really interesting, that all the 4 people who died, they died in this age span, including this stormy aggravation of the neurological condition and the epilepsy. And also the other patient in the literature described for being that in this subgroup, and I mean in the subgroup of severe developmental epileptic encephalopathy, they died as well at the same age and in the same condition of an extreme worsening of their condition. So that means that it's not unpredictable. This is a predictable death, and it's, I would say, possibly preventable. Not sure it's preventable in any case, in all the cases, but this patient has to be strongly supported in this phase. And actually, this accounts for 7 out of 9 of the case of death in all the SCN8A patients. So it's the big proportion of patients died in this condition. So if you look at the global mortality rate, you see this is the number of deaths and the age of death. And in blue, there are the probable or definite SUDEP, which are 2 clustering at the teenager age and 1 an early age, while the biggest amount of patients who died, they died in this age span here, and almost all of them, all but 1, they belonged to the severe phenotype. So that means that this is a critical age. This is a mechanism. This has to be, we have to be aware of this. We have to fight against this and to support them really, really well at this point. So that maybe there is, among these patients, maybe there is a mechanism which reminds the pseudomus side for the, I mean, they can die because of a seizure, but in a quite peculiar way, in an extreme degeneration, and which by definition is not considered SUDEP. We discussed this with Thomson last month, which is the expert in SUDEP actually from Sweden. And then the milder phenotype, they die actually for reasons that seems to be more related to SUDEP. They can die at both age, early or later on, but actually there are not that many, fortunately. So the conclusion, I think I'll focus, I apologize if I will be too fast at hurry, but we'll really focus on this aspect because to me it's the most important at this point, is that the early mortality rate in SCN8A epilepsy has been underestimated, it's not 0, but it has to be reconsidered, and especially SUDEP has to be reconsidered. The overall mortality rate is, we are computed at about 5%, and probably if we diagnose much more cases in the milder phenotype, probably will follow down a little bit more. And the early mortality rate related to SCN8A is even a little bit lower, because we remember that there was one patient died, but not because of cancer. So. And the SUDEP rate, I mean, definite and probable SUDEP, not the possible one, is not that high, it's 1.6. And the mortality rate differs between the patient with developmental epileptic encephalopathy and that means the severe phenotype and patient with a milder phenotype. This has to be confirmed, supported from further studies, but we have quite a lot of patients, so we are quite confident that this might be a trend. And the last but important thing, that the biggest proportion of the patient would die in the severe phenotype. There are 7 out of 9 of the precocious mortality patient. They die because of a worsening, or extreme worsening of their neurological and epilepsy condition. And this is not so that this has to be supported, and this is highly expectable, unfortunately. I do thank you really much. I thank you all the collaborators. Some of them are inside in this room for supporting also this study. Thank you so much. Thank you.
we'd like to take a couple minutes to acknowledge our memorial moments for 2018. Just waiting on our slides here. Since 2011, the SCN8A community has been touched by the loss of 15 of our own. All 15 of these children and babies left behind families who protected them, fought for them, had dreams for their futures, and loved them dearly. They each made up a part of our SCN8A family. Sadly, some of these faces may be familiar to many of you, but 5 of these children are new to you. They lost their lives in 2018. Our community refuses to accept these losses. Our children are not statistics. Let's take a few moments to acknowledge, honor, and reflect upon the lives of each of our SCN8A angels. Shay Hammer. James Cleary. Tristan Tong. Easton Brunty. Rebecca Owens. Jacob Falls. Dustin Jenkins A. Bruno Wagner. William Ramirez. Joshua Oren LeBouve. Jackson Nicklin. Declan Bell. Nell. Emerson Mascherino. Angelo Ibrahim. All of these children have legacies that will live on through each of us by way of successful treatment and improved quality of life, breakthroughs and advances in scientific research, strong patient advocacy, and family support. I'd like to invite up Hilary Savoy. Hi, everyone. As many of you know, I'm Hilary Savoy. I am the founder and co-executive director of the Acute Syndrome Foundation. My foundation partner, Julianne, and I envisioned this event as an important opportunity for SCN8A clinicians, researchers, and families to come together around our shared goal of improving the health and safety of those with SCN8A. After our first gathering, and as we saw a handful of individuals really rising to the occasion, Julianne suggested creating the Cuties, our annual awards for champions for understanding, treating, investigating, and empowering those with SCN8A. Although sadly Julianne is not here today, she wasn't able to travel for the event, it is my pleasure to give these awards tonight on behalf of Julianne and myself. The first award tonight is for an outstanding researcher, for a champion in investigating SCN8A. I can speak very personally to this individual's dedication to this community, including his willingness to help me investigate the complex poetry of my own daughter's collection of mutations. However, his reach in this community has been much broader than just that. When I asked for comments from our volunteers about the individual receiving this award, they mentioned a number of things. His engaged presence at all of our events, his patience in explaining his research and the research of others to parents, often over drinks after this gathering, his exceptional beard game,
his video of his incredible NAV 1.6 model that made our whole community say a collective, "Oh, that's how that works." So for his efforts in SCN8A research, I would like to present this Cuties Award to J.P. Johnson, Jr. The next category is for an outstanding family member, a champion in empowering those with SCN8A. This awardee was one of our very first volunteers at the Cute Syndrome Foundation. While she is raising one of the more fragile children in our community, she never shies away from taking on difficult, complex, and long-term tasks. Although her son has faced an unbearable amount of hospital stays this year, she trucks along, completing tasks from his bedside. She is very often the first person in our community to offer to help with any task, the first to praise the other volunteers and their work, and the first to offer support to those in need. She has attended and been an instrumental volunteer in all of our previous gatherings. And while she wanted to make it here to New Orleans this year and held out hope until the very last minute, her son's sickness and a nurse cancellation required her to stay home this year. She's not here in person, however, she is watching online, hi, for her amazing ability to turn the extreme challenges her son faces into an advocate's focus. It is my pleasure to offer this Cuties Award to my friend, Dianali Cabrera. So I'm going to send this along to her just as soon as possible. So thank you, Dianali. Now, for our final category, our Clinician Cuties. This year, as Julianne and I discussed, who would join the late Dr. Mandy Harris and Dr. John Schreiber in receiving this award for a clinician that would go above and beyond in helping our community. We realized that at this moment, there just wasn't a clear choice to join them. The last few weeks, as you can see, in our memorial moments have made it painfully clear to us as a community that clinical care for children with SCN8A needs to improve. We need more clinicians to be active in our community, more clinicians to collaborate with John, more clinicians to step up as consulting physicians in SCN8A cases, more clinicians to talk to their colleagues about how to treat and how not to treat individuals with SCN8A. So I'm going to set this award here as a call for the clinicians in the room. Make it yours next year, please. And so in this vein, I do have an announcement, however, to make that's not on the schedule. In a series of discussions with John Schreiber around the difficult loss of 2 infants in our community last week, we've been focusing on how to improve the awareness of best practices for treating individuals with SCN8A. As a result, the Cute Syndrome Foundation is proud to announce a clinical grant to Dr. John Schreiber. We will be partnering with Children's National Medical Center on a 6-month pilot study to evaluate the access to and increase awareness of SCN8A treatment recommendations from experts in the field. This study will result in a better understanding of those factors that prevent access to consensus recommendations, to increase provider knowledge, to improve utilization of appropriate anti-seizure therapies, and to pave the way for future interventions, with the end goal in mind to reduce the mortality and improve health outcomes for all those with SCN8A. Thank you, John, for your continued dedication to our community. And as long as we're speaking about exceptional clinicians, it is my honor to introduce the first of our recipients of our Dr. Mandy Harris travel grant. We established these travel grants to help support families in coming to this event because it is costly and difficult for them to do so, but much as Dr. Harris would approve of, it is incredibly important for these families to be here to learn what's happening in the clinic and in the research labs. And it's also really important for all of those of you who are professionals, medical professionals, to be learning from the families as well. So I'm going to invite up Mary Withers' parent.
Hi everyone, my name is Mary Withers and this is my daughter Sarah, and we've travelled here from Glasgow in Scotland to represent my daughter Rebecca, who is 19 years old. Her epilepsy journey started when she was a 4-month-old girl, but only diagnosed with SCN8A 2 years ago. She's currently at home with her dad and her younger sister, Jennifer. I'll pass you on to Sarah now, who's got a slideshow for you.
So over the years, Rebecca's spent a lot of her life in and out of hospital. She's tried many medications and been on the ketogenic diet. The only drug for her to ever control her seizures to an extent has been phenytoin, which she's been on since she was 4 months old. The drug for her has not come without problems, and there have been periods of her life where she's had extremely high levels and extremely low levels, both with bad side effects. When at its lowest, her consultant attempted to wean her off it, but her body couldn't cope with this and she became very unwell and she regressed and lost a lot of her abilities and was in hospital and off school for about 6 months. At its highest toxic level, she was seizing constantly and suffering very violent thrashing episodes with involuntary movements. After a diagnosis of SCN8A, she started on lacosamide, which seems to work well for her alongside the phenytoin, but she's still never been seizure-free. Becca's a happy, smiley girl who's full of life despite all she's been through. She's in a wheelchair but can walk a few steps with 2-person support. She's got an obsession with pairs of things and has to have something in each hand. She can only eat soft, pureed foods and receives milk feeds and all of her meds through her gastrostomy. She can't speak but has a few vocalizations and laughs a lot. She loves anything with a bit of a thrill, whether it be an accessible speedboat, go-karting, or swinging from an aerial trapeze beam. But life with Rebecca is anything but predictable, and she's spent an incredible portion of her life in hospital. And as she's got older, seizures have got worse, and more recently she's experienced a lot of long 35-minute tonic-clonic episodes. And this was just a week ago today. She had 25 seizures in just under 12 hours. But of course, it's the bad times that make the good times so special, and her smiling face brightens up our lives every day.
Lastly, we'd like to thank all the volunteers who have helped organise this event. And also, thank you to the Mandy Harris travel agent for donating 2 prizes, one of which we were lucky enough to win. Finally, a huge thank you to Rebecca's medical team back in Glasgow, especially her consultant, Professor Zamir Zuberi. He's actually here in New Orleans this weekend for a conference, so who knows, we might bump into him. He has been caring for Rebecca since she was 6 months old. We are blessed in Scotland to have a service, a national health service, providing excellent care in all fields. We are looking forward to being part of the gathering this weekend and meeting everyone in person. Thank you.
Our next Dr. Mandy Harris travel grant is actually partially sponsored by Southwest Airlines, who generously donated tickets to help make this possible. We'd like to welcome up Casey Craig.
Hello. My name is Casey Craig, and this lovely lady up here is Stella. She started having seizures when she was 6 weeks old. We got her diagnosis when she was about 5 months old. And since then, she is pretty much on the more severe end of things. When I look at the group that Dr. Hammer talked to you about, we are very much in the group A, the SCN8A plus group. And looking forward to talking to you more about that tomorrow. So with Miss Stella, I actually had the pleasure of being the guest lecturer last year. So I don't want to talk completely about what I talked about last year. So I do want to touch on something that I think has really hit us as a group over the last year, and it's really hit me hard, is the quality of life of our kids and how as parents we are having to make very difficult decisions on what is quality of life for our kids. And Stella, she was having a really hard time with seizures. She really has her whole life. And we were in a bad place last December after we came to this conference, and she had an EEG, and she was having over 50 seizures a day. Some of them I would recognize, and some I did not. And we started a new medication, and after we weaned off phenobarbital, she came to life. And we got to see Stella. We got to see personality. We got to see this child that's over here to the right, smiles and giggles. I tickled my daughter, and she smiled, and she laughed, belly laughed. And what an amazing thing to see in your child. But she still was seizing. One cold. We were airlifted twice in 2 weeks in status. Hours and hours of cluster seizing, and we could not get it under control. So we decided to add another medication. And when we did that, it was like, wait a minute, we're not seeing a seizure, and it's been a couple of days. Oh gosh, don't say anything, right? And then it was a couple of weeks. And they're like, oh my gosh, look what's happening. So we started weaning off some other drugs that just weren't helping seizure-wise. And we saw her the most interactive we've ever seen her. And within a week, all the smiles went away. All the giggles went away. And we don't know exactly what happened. So we have this amazing seizure control for us, right? And Stella has not had a seizure since September 6th, which is our all-time record high. There's this monster we talk about as parents, a monster in the corner. That's what we call seizures. And they're always lurking. It doesn't matter if it's been 2 years, 5 years. It's always there. And so I've been able to let my guard down some, right? Like, oh, I don't have to watch her every 15 seconds. I might be able to run to the bathroom and come back and not be fearful that when I come back, she's seizing. But I don't have my Stella. I don't have these smiles. You can see the ones on the right were before, and the ones on the left are what she is now. She's still in there. I know she is. We started a communication device with eye gaze. My husband said, Stella, pick the car. She picks the car. She's in there, and we can't get her out. Of course, we are making every effort with our epileptologist. That's amazing. But as you know, we have to go very small, very, very slow. And then you have cold and flu season. So we almost have to pick. Do I not end up in the helicopter every couple weeks because every time she has a cold, she's going to cluster seize and go into status? Or do I get to see my child smile and interact? So I beg of you, the researchers, the clinicians, keep trying. Keep going, keep researching, because it's our children, it's our quality of life. And I hate to make that decision. It's really hard for parents to make that decision, as well as our clinicians. So I thank you for coming here. Last year when I came to this event, it's like it feeds our soul to see that we're not alone, because we feel very much alone. But we come here and we see all of you working for our children and caring for our children, even though you've never even met them. So thank you so much for coming here and for doing this. And thank you so much for the Cute Syndrome Foundation for supplying us means so my husband and I can both come to this event and both get a little bit of a break. Those parents, you understand, but also get to mingle with other parents that actually understand what we're going through. So thank you.
I'd like to invite to the stage Dr. Jc Wagon.
Does this pointer work? Maybe not. Okay, well, thank you. It's an honor to be here again this year and be able to talk about my research. And last year I mentioned that we were developing a new mouse model of SCN8A epilepsy, and so this year I'm pleased to report some of the things we've been finding with that new mouse model. When I first started in SCN8A research about 5 years ago, there were half a dozen mutations that we knew about. And so now in 2018, there's over 250 individuals who have epileptic encephalopathy with SCN8A mutations. And these are just some of them on this schematic. So each dot on this channel cartoon, this is our sodium channel SCN8A, and it has these 4 domains with these 6 transmembrane segments. And each dot on there is a different variant. And the open circles are recurrent variants, which are occurring in one or more individuals. And so I work with Dr. Miriam Meisler, and in our lab we are developing mouse models so that we can understand more about the pathogenic mechanisms underlying this epilepsy and provide these models for preclinical testing of new therapies. And so the 2 mutations that we have mouse models for are shown. The first one was the original mouse, asparagine 1768 to aspartate, and that's at the very end of transmembrane segment 6. And then the new mouse model, which I'll be speaking about today, is a conditional mouse who has the variant arginine 1872 to tryptophan, and that's there in the C terminus. So here's a summary of these 2 mouse models. For the N1768D, we've knocked that one into the endogenous SCN8A locus, and that mouse does recapitulate seizures, and it also has early lethality. So the onset of seizures in that mouse is about 2 months of age. And interestingly, there's only 50% penetrance of the phenotype in that mouse model. So we wanted to develop a second mouse model, and the criteria were that we wanted to model a more severe allele, and you can see the comparison of the patients up there. And we also wanted to make this conditional. So this is helpful in a few ways. One is the original mouse is fairly hard to maintain because they have that early lethality. And if we have a conditional allele, this is going to allow us to activate the mutation using genetic techniques, which I'll describe in a moment. And so that will be easier to maintain. It will also allow us to dissect some of the neuronal contributions to epilepsy, so we can look at different neuron types, and we can even look at brain versus cardiac expression of SCN8A. And we were hoping that by modeling this more severe allele, we would get increased penetrance and have a better model to study for treatments. Right. So the biophysical effects of this variant are shown here. And so when we have looked at about 10 variants of SCN8A and looked at their functional effects, and we found that they all have these gain of function. And what we mean by that is they've developed a function the normal channel doesn't have. And in this case, they're usually making the channel, they're always making the channel hyperactive. And there are a couple of ways this can happen. For the 1872 mutation, what happens is we have this elevated current density. So the wild type currents are shown there, and you can see the sodium current come in as that dip in the current, and then as the channels, that's the channels opening, and the channels closing are it going back to that baseline amount. And below that, the arginine 1872 tryptophan mutation has more of that sodium current that's coming in. And the other thing that I hope you can see is that the channels are not closing appropriately, so it never quite gets back to that flat baseline. And on the right, you can see this because we've normalized that current. And so that black line is the wild type, which quickly closes and goes back to baseline. However, the mutation is causing this slowing of inactivation, so they're not closing as quickly. And so this channel has an impaired inactivation.
It's not. Oh, there it is. Well, push the button harder. Well, that was a good exercise to explain that. So this is our conditional allele. So we can take advantage of the fact that this C-terminal variant is encoded in the last exon of SCN8A, and that's exon 26. So we've duplicated this last exon, and the first copy, which is 26A, has the wild-type arginine, and it's flanked by LOX-P sites, and it also has a bovine growth hormone poly-A. So without doing anything else, adding any sort of Cree recombinase, we get the transcription splicing from exon 25 to exon 26A, and we get a completely wild-type channel. However, the downstream exon, we're calling it 26B, encodes the tryptophan, and this has the endogenous 3' UTR. So after we cross in Cree recombinase, the wild-type exon gets excised, and now we have splicing from exon 25 to exon 26B, and now we get the mutated channel, the R1872W. So the first thing we did was to actually look at is whether this allele is functioning as we've intended, and we can look at this at the DNA level and the RNA level. So in the DNA level, when we have this conditional allele, we have different restriction splicing patterns that happen. So here's wild type. In the conditional allele, we get the presence of these new restriction fragments. And you can see here in a homozygote that we have the conditional allele is digesting as expected. And then we can also tell whether this has recombined, so whether the Cree has efficiently excised that first exon. And we look for the presence of this new restriction fragment here. So here's a Cree. This is an E2A Cree, which is a ubiquitous Cree, and it's expressed very early in pre-implantation embryos. So this is basically like having a germline copy of this mutation, and we can see the presence of the recombined form. If we look at the brain RNA, again, we can see by differential restriction digest whether we're getting actual RNA transcripts from our recombined allele. And again, we're using the E2A Cree. In the absence of Cree, we get the expected pattern, and then when we have the Cree present, we can see the presence of this band here, which suggests or indicates that we are getting the correct expression. So this allele is working as intended. It's very clean. We don't see expression of the mutant transcript when we don't have Cree present. So in the E2A Cree mice that are expressing R1872W, we do see this early lethality. And so here's the conditional without Cree. So these are basically having wild-type channels. And then we see by about 2 weeks of age, we start to get seizures and sudden death in the mice who have the 1872W. And we are seeing 100% penetrance for this early lethality. And it's earlier, it's much earlier than the 2 months for the original mouse. This is starting at 2 weeks of age. And what's happening here on the EEG, this is cortical EEG in the left cortex and right cortex. We have this EMG measuring movement activity, and then we have EKG. And almost all of these mice have a single catastrophic seizure and then sudden death. And so the beginning of the seizure is this running phase, so they run wildly kind of around the cage, and then they have their seizure onset with tonic extension. And when the seizures start, we actually see a slowing down of the heart rate, and eventually between 30 seconds and a few minutes, we actually can see that the mice have died with their heart rate stopping. So what's happening in the brain of these mice? So we have, in collaboration with Manoj Patel's lab, looked at firing in hippocampus and cortex of these mice. So CA1 is the region of the hippocampus, and here's the cortex. And we do see increased action potential firing in both regions, and then that's quantified here as well, where the black is wild type and the blue is showing that we're having increased frequency of action potential firing in the mutant mice. So they have this neuronal hyperexcitability and increased action potential firing that's underlying seizures in those mice. And so what we were interested in looking at was actually the contributions between different types of neurons, so excitatory neurons versus inhibitory neurons. And so we took advantage of our conditional system to look at some different Crees that are expressed differentially.
So the first one is nestin Cre, and this is a pan-neural Cre, which is in all neurons and some non-neuronal cells in the brain. And here we see a similar pattern to what we saw in the E2A Cre mice. It's slightly delayed, but we see 100% of the mice are dying before 2 months of age. When we have this mutation activated in excitatory neurons using EMX1 Cre, which is in forebrain excitatory neurons in the cortex and the hippocampus, again, this is sufficient to cause the seizures and the sudden death, although it is more broad than when you have the whole brain affected. Oops. Can we go back? Can we go back? Okay. And so what we also did was to activate this mutation in inhibitory neurons only, and we actually used 2 different Cre lines. One is the GAD2 Cre, and the other one is DLX5A Cre. So this should be affecting almost all the inhibitory neurons in the brain, and we see no phenotype at all. So these mice are indistinguishable from wild-type littermates. They're not having seizures. They're not having abnormal EEGs. And from what we can tell from some motor assays, they're not having any motor impairment either. So SCN8A is expressed in excitatory neurons and in inhibitory neurons, but it seems that the excitatory neurons are playing the prominent role in underlying the seizure phenotype in SCN8A epilepsy. And then another thing we can do with this conditional system is look at the role of development in epilepsy, and we can basically ask the question, what happens if we just activate this mutation in adults, so past the developmental stages of the early ages of the mice. So we can do this using an inducible Cre. So this Cre is fused to the estrogen receptor promoter, and it's not activated until you give the mice a drug called tamoxifen. And once you give them the tamoxifen, then you're activating the mutation. And we saw that here, this is the percent of mice with seizures, and 100% of the mice had seizure onset by 4 weeks of age, so half of them at 2 weeks. And then we looked at the survival after they had seizure onset, and again, 100% of the mice do end up having lethal seizures, starting at 6 weeks of age and then continuing on till as long as 2 weeks of age. And again, we can monitor that we did actually get expression with the tamoxifen treatment. So here's the mice that don't have Cre do not have any recombination and don't show this mutation being active. But then when we have the tamoxifen and the Cre, we see that we got robust activation of this mutant allele. And so this mouse is very useful for looking at treatments because we have 100% penetrance and we have this very tight timeline of seizures and sudden death in these mice. So if we treat them, we can do a shorter term treatment and see whether the treatment has been effective. And so one of the treatments, which you'll hear more about later tonight, is this Prax-330, which one of the mechanisms that it does is it reduces persistent sodium current. And here's the E2A Cre data again alone. And then the Prax-330 treated mice had a significant increase in their lifespan. It was about a 1 week increase, but it's very significant compared to the E2A Cre. So while they weren't completely rescued, this is a very promising result actually because this is such a severe mutation. The fact that they were rescued for a week is quite significant. And here in the final slide, this is just showing, this is some more data from the Patel lab showing that Prax-330 does normalize some of those biophysical defects that were caused by 1872W. So here's this current density, and that the 1872W causes this increase in current density, but the Praxis normalizes that somewhat. It also causes a left shift in the inactivation, which means that the channels are closing more properly. And here's a zoom in showing that it is normalizing some of this persistent current back to more wild type levels. So in conclusion, I think this is a very exciting new mouse model. It's inducible, and it has this it has this this R1872 tryptophan allele is the most commonly recurrently mutated allele in SCN8A so far, with over 14 individuals carrying this mutation. The global activation does result in the 100% penetrance of the seizures in the sudden death phenotype, and we've shown that it's the forebrain excitatory neurons that are playing a very prominent role in the seizure etiology. So that means that the excitatory neurons are actually a critical target for intervention. So some of the therapies that people are thinking about, there are different viruses and things that will selectively target different types of neurons, and so excitatory neurons are a critical target for that. We've also showed that the activation in adult mice is sufficient to cause seizures and sudden death. So this sodium channel mutation, it's not just changing the brain during development. If it's active only in adult, it's still going to cause the seizures. And the Prax 330 can rescue the channel defects and did prolong survival of the mice. And as we do more research and find more ways to possibly intervene in this disease, this mouse would be really useful for testing of those new therapies. And with that, just acknowledge the members of our laboratories and others at Michigan and Virginia, including the Patel Lab and Howard Gibson's lab, who helped us do EEG. And then thanks to the Acute Syndrome Foundation for hosting this event.
Keep hold of it in case there are questions.
We would like to welcome to the stage Dr. Andrew Tickle.
All right, first of all, I'd like to thank you for the opportunity to come and speak today and give an update on my research. I was able to present this, a little bit of this story a couple of years ago, but I'll be adding to that. So I'll be talking about patient-specific sodium current abnormalities in SCN8A iPSC-derived neurons. So the takeaways that I'd like to have you come away with today from my talk are that there are patient-specific differences in sodium current abnormalities. It's probably not something new for this community, but there are some nuances that I think we're seeing in some of our cells that is a bit new. We see, at least in this model system, shorter axon initial segments in patient neurons. We've only seen that in this culture system, though, but it's an interesting finding that may be compensatory in this disease. And then lastly, we see increased patient neuron bursting phenotypes. So we use iPSC-derived neurons in Jack Parent's lab at the University of Michigan. So these are cells that are generated originally from patient cells. We derive these from a small skin biopsy and then reprogram these into induced pluripotent stem cells, which are the equivalent of an embryonic stem cell. And the real excitement about these cells is you can differentiate them into any cell type in the body. So we can differentiate these into neurons that have the full genetic makeup of patient cells. So for our study, we've generated these cultures currently from 3 different patients and 4 controls. And so the mutations for the 3 patients are listed here on the same diagram that Jc showed just a minute ago. So we have, all of them are in domain 4. We have a 1872 mutation. It's not the tryptophan, it's the leucine variant. We also have a 1759 and a 1592 mutation. And this is some of the patient information listed up here. I'm not going to go into all these details just because of time. But one interesting thing that we have been able to generate is a line that's a rescue using CRISPR. It's not a correction of the mutation. We've been able to knock out the patient mutated allele. So this is a hemizygous line that expresses only wild type. So this might be some new type of data for people not familiar with iPSCs, but these are just showing that lines that we've generated from these patients express normal pluripotency markers. So this is immunocytochemistry in these cell lines. And this is showing on the right for some of these lines that they can be differentiated into all 3 germ layers. These are markers of the 3 embryonic germ layers. So these are truly pluripotent stem cells. So to get from a stem cell to a neuron, we follow a normal developmental program that's in all of these cells. So we use some inhibitors that direct them down the neuronal lineage. So this is called dual SMAD inhibition, and this converts the iPSCs into early neural cells, and then we mature these over a very long time in culture to generate mature neurons that express many of the normal channels that you would have in a neuron in the brain. And so this is showing some immunocytochemistry from one of these cultures. So in green, we have VGLUT1, which is a marker of excitatory neurons, and in red, GABA, which is a marker of inhibitory neurons. And MAP2 is a marker of somewhat mature neurons, and you can see most of the cells are VGLUT1 positive and MAP2AB positive. And we've quantified this to show that, really almost all of our cells express VGLUT1, but the reason we were looking at this is we wanted to know what the level of GABA was, to know how pure our cell cultures were for excitatory glutamatergic neurons. As Jc just showed eloquently in her talk, really it seems that the disease is due to the mutation being expressed in the excitatory neurons, and that's what we focused on in this study. In addition to the cells mostly being VGLUT1 positive and a small minority of the cells being GABAergic, we also quantified a marker called CTIP2. It's a marker of deep layer cortical neurons. So this is the largest classification of neurons in these cultures. So in collaboration with Laurie Isom's lab and 2 exceptional electrophysiologists, we've been able to collect data on these patients. So these traces won't be new to you after Tracy, so I won't go into all the details of what they're showing, but these are sodium current traces. This is for one of our controls and 2 of our patients, and this was done by Luis Lopez Santiago. And what I'd like to point out is that for both patient 1 and patient 2, we see an increase in persistent sodium current. And this has been shown in many models now, in both the animal models and in the heterologous expression models. And this is an example of one of the neurons that Luis patches. They're expressing a CAMK2 alpha-driven GFP. So this is another way that we ensure that these are fairly mature neurons and also excitatory. And then this is showing the sodium current trace at about 50 milliseconds when we quantify the persistent sodium current. And again, showing that both patient 1 and patient 2 have this elevation in persistent sodium current. And we've quantified this now, and we see that even though we have a trend, we don't see a significant difference in the peak sodium current. You can see that bit of a trend here between the patients and the control for reduced sodium current, but it's not significant. But when we normalize the persistent to this peak sodium current, we see a significant increase in both patient 1 and patient 2. When I showed you that we have a rescue iPSC line, and when we looked at peak sodium current, we actually have an elevation. So this was good to ensure that the hemizygous mutation was not leading to a severe loss in overall sodium current. But then when we looked at the persistent sodium current, it completely rescued the phenotype and went back to equivalent levels to the control. Patient 3 was interesting to us because we did not see this elevation in persistent sodium current. So we wondered, what is the mechanism in this of this patient? What Luis found was when he did a program in his recording looking for resurgent sodium current, we saw an increase in the resurgent current in patient 3 that we did not see in the controls. And so this is the resurgent current right here. And when we quantified this for our 3 patients, we only saw an elevation in resurgent sodium current in patient 3. So it seems like we have this this difference between patient 1, patient 2, and patient 3. And perhaps this is a way that we can further classify the patient variants. So in addition to the sodium current recordings, Yukun Yuan in Lori's lab also did some passive recordings and some current clamp recordings. And what he found was there seems to be a trend for an increase in spontaneous activity, but in particular, an increase in burst firing that you can see in both patient 1 and patient 3. And an interesting thing that he noted for patient 3 was that there were these early after depolarization events that occurred, and these are during the time when the cell should be refractory. And so we think that this might be an outcome of the increase in resurgent current. So as I said before, we also see an increase in or a decrease in the axon initial segment length. So the axon initial segment is the main location of the NAV 1.6 channel. This is where the action potential is initiated. And so you can see that labeled here in red. So this is marked, labeled for anchorin G. And I just have the arrowheads showing the length. It's a little bit hard to see in here. But when we quantify the length for our controls in patients, we see a very consistent reduction in the length for all 3 patients compared to controls. So I'm plotting that here just as an overall mean, and on the right this is the cumulative distribution plot, and you can see the shift to the left towards shorter lengths. One interesting thing to note, we don't know how relevant this is, but we have one patient that seems intermediate, so patient 2 is intermediate between the 2 groupings. And this patient seems to have one of the a less severe phenotype, at least to date. So one other thing that we wanted to do with these cell cultures was to look at overall network activity. And one of the problems with iPSC-derived neurons, especially the dual SMAD flavor that we've been generating, is it's quite variable when we form a network. A lot of that has to do with just the heterogeneity of the cultures. So it's worked out very well for us for patch clamp recordings because we can mark the cell types that we want. So going forward, what we've been doing to look at network activity is generating eye neurons. Just for the sake of time, I didn't go through all the details of how to generate these, but these are cells that have a doxycycline-inducible neurogenin. So they very quickly, over the course of a week, go from being an IPS cell into a neuron that can fire action potentials. And so with this, we plated these on these multi-electrode array microplates. So these are 96-well plates, and in every one of these wells, there's an array of 8 electrodes. And the data that we collect from these electrodes is in these raster plots. And so you can see here some typical data from a control. So these are each line is from a different electrode in a single well. So we generate a huge amount of data from a single plate. And then this is some typical data from patient 1. And what it's showing are these network bursting events where you have synchrony between the different electrodes. So this is a way to look at the network activity. So the first thing that struck us was when we looked at the instantaneous firing frequency. So this is 8 wells and a single plate from control 2 compared to patient 1 on the same plate. We see this increase in the rate of network bursts. It's a little bit hard to see here. I'll be plotting some data in a minute. But what we're showing, each one of these spikes here is a network burst event. And in the controls, and then this is another plate with control 3 and patient 3, we see kind of these regular intervals between network bursting events. Now this might seem surprising because a network burst event is similar to a seizure-like event, but these are pure glutamatergic cultures. So it's a little bit different than what you would find in a normal brain slice. And in control 3, we also see kind of these regular intervals as well. But particularly in patient 1, we see sometimes this period of inactivity followed by a very large network burst and then high frequency bursting in the network. So there seems to be these differences in how the network activity unfolds, whether it's a SCN8A mutant or a control. So this also occurs for patient 3 as well. So when we quantify some of the output measures from this network activity, the first thing that we were surprised by when we compared patient 1 to controls was that there wasn't really an increase in overall activity in these cultures. But when you looked at the Interspike interval coefficient of variation, which is a measure of burstiness, how much activity is in bursts, we see a very dramatic increase in patient 1 compared to controls. And I'm plotting it as individual patients because we did paired analysis within plates just to reduce the effective variability between plates. Oh, sorry, this got cut off right here. But this is burst duration. We see an increase in burst duration. We also see an increase in the percentage of spikes that are in network bursts. And really, these are just additional measures of how bursty are these networks. We quantified this also for patient 3. And an interesting side point I'd like to make is that for patient 3, we see this increase in overall activity, particularly when the cells are less mature and haven't formed as synchronous of a network. But for these two measures, we see a similar increase in the bursting within the network for patient 3. So I can give any more information that you would like, but I just wanted to keep it short today. So with that, I'd like to acknowledge Jack Parent, my mentor, and Lori Isom, our close collaborator, and Luis and Yukun, who generated a lot of the data for this study. Thank you.
I had a question. Have you measured SCN8A expression in any of the neurons at any stage? And I've heard through the grapevine that it's hard. It takes a very mature neuron to express 8A, and if it's not being expressed, how do you explain all the interesting patterns you're seeing?
That's a very good question. So we've looked at the expression by QRT-PCR, which is not protein expression. One of the interesting things that we find is the iPSCs actually do express a not insignificant amount of the mRNA, but we see a similar mRNA expression between the controls and the patients. We have not looked very closely at protein, except for a couple Western blots. We did see NAV 1.6, but those are the antibodies aren't great for NAV 1.6, so we've shied away from it a little bit. But we are seeing the clear phenotype that's been shown in other model systems in our single patch clamp experiments, and then also seeing the rescue with the hemizygous line. But yeah, that's a good question.
Question over here. The decreased size of the axon initial segment, have you seen anything like that in other channelopathies? And what do you think is the significance of that? Do you think having abnormal channels could actually influence the morphology, the growth of that segment?
That's another great question, one that I don't have a great answer for, but we do. So there seem to be kind of two different possibilities of what's occurring to lead to that shorter axon initial segment. Either there's some type of developmental change between the two populations, so then that's the reason for the change in size, or it could be a compensatory change. There's been some indications in the literature that, it depends on who you talk to whether they agree with it, but that with increased activity and hyperexcitability, this could be a way to compensate by shortening the axon initial segment. I don't have a good example off the top of my head, but I do know there are a few examples of VAS shortening with certain conditions. I don't want to try to rummage around to remember what those are right now, but maybe we can talk afterwards.
Okay, I just had a quick question. Do you ever see more than one AIS in these neurons? Because I know cultured hippocampal neurons can have 2 or 3, and I just wondered if you saw something like that here.
Not that I'm aware of. It wasn't something that jumped out at us, seeing multiple AISs. Sometimes it's a bit hard if they're clustering a bit, but that's not something that we've regularly seen.
Okay. Great. Thank you, Andrew.
Thank you.
I'd like to welcome to the stage Dr. Ted Cummins. Ted Cummins. Sorry, I'm a little tongue twisted. It's getting late. Thank you.
I want to thank you for letting me come and give you an overview of what we've been doing, and I want to thank the foundation for their support with the grant funding this last year. And I will say that we feel your pain, and we wish things would go faster too, but we are trying. And so I'll tell you where we're at and where we hope we'll be in another year from now. So actually a good bit of my group is focused on SCN8A right now, and the grant that we got from the foundation was to develop Zebrafish models of SCN8A mutations. And we've been working with Jim Mars and Swapnali Sarma in a lab down the hall from me, who are Zebrafish experts, to help develop these transgenic models. Pat Milder in my lab, a graduate student who joined a year ago, is helping characterize the behavioral system for monitoring the seizure activity in zebrafish. Agnes Zybera in my lab is looking at CAMK2 modulation of SCN8A and starting to use zebrafish to see if CAMK2 modulation of SCN8A can affect seizure susceptibility. Claudia Pan has done a lot of analysis of human NAV 1.6 constructs, and these are what we hope to put into the zebrafish in the next few months. And Emily Mason in my lab has been looking at using zebrafish models to probe how gating pore mutants can affect the activity in the fish. And a number of channelopathies are likely to induce gating pores, including some of the SCN8A mutants. So when we started out, we thought we'd just do CRISPR-Cas9 of the zebrafish. And Scott Baraban had done this with the Dravet syndrome model, where you just knock out SCN1 lab and you get seizures in the fish. And we were able to do that too with CRISPR-Cas9, and we got aberrant morphology, and the video didn't transfer, but we saw convulsions in the Dravet fish, and when we impaled their brain, we could see seizure activity in the fish. And we started going down that road, but the fish were not surviving with our CRISPR-Cas9 SCN8A constructs. And JP pointed out that zebrafish SCN8A does not have the pharmacology, at least predicted pharmacology, of human SCN8A. So what we switched to was using a transgene approach where we're putting the human gene in the fish. And this took quite a bit of time to get the transgene put together. It's a huge construct, 15 kb, but we've got the construct now with the human coding region in it. The construct includes an eye reporter, so the fish that we've been generating have green eyes, so we can tell we've got transgenic fish. The construct also has GCAMP running off the same neuronal zebrafish promoter that's driving the SCN8A expression. And we're starting to get fish with green neurons. The GCAMP is not that bright, at least under baseline conditions, which is what we expect, but we expect with seizure activity, we will get brighter neurons in the GCAMP. And because of the experience in mice with some of the mutants being lethal, we're also developing conditional constructs. And so we aren't quite there with the conditional constructs, but we're getting there. But we do have fish now that are expressing at least mRNA for the human NAB1.6 channel. We've got to confirm that those are functional human channels. The wild type fish look normal, which is good, but now we've got to see if the mutant fish have seizure activity. So in anticipation of that, Patrick's been optimizing the behavioral assays with PTZ in the zebrafish, and we can use this high throughput behavioral analysis system, the ZebraBox, to monitor zebrafish activity, and it monitors the movements of the fish, and with PTZ, which can induce seizures in mice and fish, you see a dose-dependent change in their behavior and their movements. And what we found is that high concentrations of PTZ can induce quite severe seizures, but appear toxic and aren't stable. So we're using lower concentrations. 10 millimolar PTZ gives us stable seizures over 90 minutes that we can screen for. And with the mutant fish, we hope to also use PTZ to probe susceptibility to seizure induction. And we can screen in the fish for anticonvulsant activity. And so this is just proof of concept with carbamazepine, with PTZ induced convulsions. Carbamazepine can normalize back to the control level. And this can be done in a high throughput manner. We use 96 fish at a time, and so we have ends of 34 to 36 in each of these groups, and so in an hour and a half you can get data on 96 fish, and you can get quite a bit of data in a day with this system. And so we're hoping to translate that into looking at multiple mutants rather quickly in the fish. And so to prepare for that, we started putting the human mutants into the human sodium channel. A lot of the work that's been published is in the mouse construct, so we thought it was important to do it in the human construct and to humanize the fish so we would have the human 1.6 pharmacology. And so this is one of the mutants we did, the R850Q mutant. This is one mutant that shifts the voltage dependence of activation and induces persistent currents. So it has mixed effects. It creates quite a large change, significant change in the persistent currents, not much of effect on the current density, and no real effect on inactivation. We've looked at 7 mutants total. Here's 4 of them that we did in the last year or so. And they do have different effects on biophysical properties, which is why we think it's important to make as many models as possible in the fish for screening, because it's likely that the R1872Q, which affects activation and inactivation in the human channel, will have a different phenotype than the R850Q, or this mutant that has a pretty strong effect on activation but not inactivation. And we also think resurgent currents are really important. And we've looked at resurgent currents with all of these mutants in our HEK cells, and all the 7 mutants that we've looked at so far, the 4 that affect inactivation all produce big changes in resurgent current amplitude, greatly increasing it. The mutants that affect primarily activation have smaller effects on amplitude, but they slow the kinetics of the resurgent currents. And so we think they're also having an impact on resurgent currents. And resurgent currents are crucial because they occur on the downslope of the action potential, and they can transition neurons from firing single action potentials to firing multiple action potentials. And to look at if those different mutants would alter firing, and if resurgent currents played a role in that. And we also think resurgent currents can be targeted with cannabidiol and other drugs. We use computer modeling to look at the impact of resurgent currents on excitability. So Claudia developed a Markov model of the different mutants, modeled the resurgent currents, and then used that to look at the impact on excitability. And this actually fits fairly well with the R1872W mouse model, where you see not huge changes in action potential firing, but you see significant changes in action potential firing with the mutants. And without resurgent currents, you have changes in firing, but they're greater if the resurgent currents are incorporated into the model. So again, we think resurgent currents can modulate seizure activity and can be an important target. And you can quantify that with a bar graph looking at action potential firing, and the R853Q mutant in the model had the biggest effect on action potential firing, and actually resurgent currents had the biggest differential effect in that mutant. But most of the mutants, resurgent currents seem to contribute to action potential firing. And so now we want to get these into the fish, see if we see seizure activity in the fish, and start screening for compounds in the fish that might be able to help patients with different mutants. And the hope, again, is that with the fish, it won't be one model per year, but that we can generate 10 models in the next year and 10 models the year after that. And we think we'll be able to do that. It won't be perfect. It won't match the human phenotype exactly, but it might give us a more rapid screening system for looking at therapeutics. And so I'll stop there, and thanks.
Questions, if there are any? So this may be a silly question, but do you think if you put the human mutation in the fish, it will seize, or do you always have to give it PTZ or some stimulant to make it seize?
We expect they'll be seizing, and we expect the problem may be they're lethal. So that's why the conditional is on the, being built. Yeah.
Very nice. I assume that's a transgenic and not a knock-in in the fish, right?
It's a transgene, yeah, a whole transgene of the whole complete human channel, yeah.
Okay, great. Thank you.
Please welcome Dr. Ian Winker.
Well, good evening, everyone. Thank you for having me here. I'm very excited to talk to you about some data that I produced really just in the past 5 weeks. Yeah, some of it I've been analyzing this week, and I'm excited about it, and I hope I can pass that along to you guys. So what I'm going to talk about is cardiorespiratory dysfunction, or the functioning of the breathing system in our hearts, in a mouse model of SCN8A epilepsy, of which we've already heard about today. And so I have signals here of EKG and EEG and breathing on my cover slide. And the purpose of studying this is essentially SUDEP, sudden unexpected death in epilepsy patients. And I don't have to talk too much about that right now, but suffice to say that we don't really know how it works. That's part of the definition, really. But it's believed that it's a dysfunction, at least in the end, of the heart or in the breathing systems that lead to death. It's very challenging to study. It's unpredictable, often unwitnessed. And so the goals of this research are ultimately to develop biomarkers and therapies to treat SUDEP. But I believe to do this, initially we need to observe the sequence of events that lead to death. and starting with life-sustaining processes like the cardiovascular system and breathing. Eventually, we can then move back and find the upstream mechanisms and hopefully treat those. So the experimental questions that I'll be addressing today are, what are the sequence of events that lead to death in these mice? And which system or systems fail? So, and there's a little bit of important methodology for this study. A good SUDEP model mouse, which we've already heard about from Dr. Wagon, and I'll touch on it briefly. And then the ability to record cardiac activity and breathing along with video EEG. And then use these to look at these parameters during terminal and non-terminal seizures. So these, as already mentioned today, these point mutations that have been introduced into mice were identified in patients who had severe epilepsy and some documented cases of SUDEP. The mice have a similar diagnosis, again, already talked about, and so I'll skip through most of that. Just suffice to say that I am using these EMX-Cree animals, which express this 1872 mutation in forebrain excitatory neurons. And they're very useful for this study because they have a fairly sharp survival curve, and yet they live to an age where we can make really reliable measurements of the breathing and cardiovascular systems. So the experimental setup looks something like this. If we're in cartoon form, we have to first measure EEG and video to properly stage the seizures. And so the mouse here is in their home cage or in a chamber that's their home with EEG leads that are attached to their head attached to a swivel so that they can move about their chamber freely, exhibiting normal behaviors. I also want to record the functioning of the heart. So I introduce a couple of leads off of this headset as ECG leads, approximating a lead 3 position. And finally, we have to measure breathing, which is actually a little more complicated. There's no electrical signal that we can record in an awake animal that gives us a breathing signal, at least not very well. And so what we do is called whole body plethysmography. This involves putting the mouse in a nearly sealed chamber except for a constant airflow that's passed through to keep oxygen and fresh air coming in, and then using a very sensitive pressure transducer to measure the really small changes in pressure that occur when an animal breathes in and out. All of this data is amplified, digitized, and then recorded on our computer, and all the figures that I show you, EEG will be in black, ECG will be in red, and the breathing trace will be in blue. Okay, whoops. And so this is what it looks like in the flesh. A little bit different than the cartoon, but you get the idea with the addition here that we have water and food, so these animals can be monitored 24 hours a day. I don't know if that's playing. I hope that's not a sign of my other videos not playing. Okay, so what does the data look like? Something like this. When I show you, this is an animal, this is a mutant animal, but it's during a calm period. They're not having a seizure. They may be in non-REM sleep here, actually. And so we have even breathing and a steady heart rate. We can expand it out to see things a little better. In the airflow trace, which is the indicator of breathing, everything that falls below this dotted black line is a breath, each individual depression in the trace. So we can count the breaths and get breathing frequency and can see apneas if they occur. We can also get tidal volume, although I'm not going to show much on that today. And this is actually what we call an augmented breath or a yawn, which some of us might be doing at the moment. We can also count these ECG spikes, and just to show you that they look like an ECG if you've seen one. My mouse ECG doesn't look quite like what a human's does. They have heart rates at 600 per minute as opposed to the 60 or 90 that we have. But you can see nice ECG waves. We also get some EMG artifact quite a bit because the shape of these waveforms is pretty similar, so it's hard to filter them out. This can obscure the ECG signal, sometimes as you'll see in the slides, but it's also somewhat indicative or informative of what's going on during the seizures. Okay, so I hope this works. I'm going to show you videos of a few seizures that we get. If you focus, well, actually, I hope I am. Can you guys see if you can push the, like this play thing? No. Sorry. the wrong button. Thank you. If you're going to focus on anything right now, focus on the image here on the bottom, the video here. So the seizure is starting now, and initially heart rate increases and breathing increases. Oh, okay, this is a non-apneic seizure, but we can go in that order. And in this, you can see the animal is convulsing and moving around. So that creates a little bit of noise, but we can see essentially that during the entirety of the seizure, in this case, breathing frequency is elevated, heart rate is actually elevated. It doesn't stop all the way to the end of the seizure. The animal is doing, looks like a grooming behavior, but it's kind of a clonic activity. And then I actually skipped a slide, but we can play maybe. Okay, so is it going to play? So that was a non-apneic seizure, where the animal continued to breathe and have a very high heart rate during the seizure. And can you guys play this one? Sorry. This is an apneic seizure, so we'll see an apnea. Again, focus on the animal in the red box there. In just a moment, the seizure will start. Yes, okay. Initially, we see an increased heart rate and an increased breathing frequency in this animal. And in just a moment, about halfway through the seizure, after a few convulsions, the heart rate, we can see the heart rate slows here, and now the animal there's a lot of muscle activity, the EMG, and the animal is in sort of a tonic extension phase. And during this time, if you look at the blue trace, there is no breathing going on. This animal is totally apneic. As this EMG decreases, we can start to see that there is a heartbeat, although it's very slow. And now we can see some gasping going on. Heart rate picks back up and actually becomes elevated past a normal baseline heart rate. And the breathing eventually picks back up while they're in the post-ictal phase. So they'll lay here for quite some time, but the breathing will be elevated. Okay, so we'll skip past this one. So we can look at both of these seizures. This is the same animal. Actually, I think it was the same day that they had both of these seizures. And we can line them up by seizure start time. On the top is the apneic seizure, and underneath is the non-apneic seizure. And you can see that at the beginning of the seizure, well, first of all, if we just look at the EEG, they look very similar. And then if we look at the beginning of the seizure, we have an elevation of heart rate and an elevation of breathing frequency in both cases. In the non-apneic seizure, this continues the entirety of the seizure and a little bit after until breathing and heart rate go back to about normal. But in the apneic seizure, we get this tonic muscle contraction, apnea, and apparent bradycardia. So the last video I'll show is a terminal seizure, and as you'll see, it looks like an apneic seizure. So this one starts up pretty quickly. This animal is starting a seizure. We have initially, again, we have an increase in heart rate, increase in breathing. Now, in these, it's noisy, but in between we can see a slowed heart rate, and then this tonic muscle activity, and breathing stops again. On a similar time scale to the apneic seizures, the muscle activity decreases over time. Eventually we can see some heartbeats, although very slow. However, in this case, the breathing never recovers, and they never take another breath. And if we speed this up over the next few minutes, their heart will eventually stop. Again, if we line up the seizures and compare, so this is terminal versus non-terminal, the non-terminal apneic seizure, we can see that they look really similar, both in the EEG waveforms and also in the ECG and breathing traces. They go through this phase of elevated breathing and heart rate, but then it stops when the EMG activity increases. And in the apneic case, after the EMG activity wanes, we get an elevation, a return of breathing and heart rate, but not in the terminal one. Okay. So conclusions from this. I asked what the proximal sequence of events is. So first of all, these SUDEP events occurred during seizures. We sort of already knew that because we'd monitored the EEG in these animals, and we knew they had seizures and then never moved again. But now we know that the breathing actually stops during the seizure, and that's the sort of the end. There's both apnea and significant bradycardia during the seizure, so both systems are affected. Which systems fail? Breathing fails and never recovers, so that's ultimate. There is a reduction in heart function, but it does continue to beat. Furthermore, there are at least 2 types of non-terminal seizures at stage 5 in these mice that I use, apneic and non-apneic. And terminal seizures look like the apneic kinds. And I think this raises 2 questions. One, can apneic seizures predict, if you're having apneic seizures, could that predict a SUDEP event? And 2, what is it that in an apneic seizure that causes breathing and heart rate to come back? And that's sort of, I think, the bigger question that I'd like to answer, and we're going to be working on. And it requires an understanding of how these systems are modulated by the brain and where the seizure is occurring. And so I won't go through this complicated slide, but there are numerous systems: the breathing control system, the parasympathetic nervous system, the sympathetic nervous system, and then this is a few sensory systems that modulate these. But the point being that it's complicated, but we know some of the pathways that are involved in this, and we can try to dissect them with things like pharmacology to modulate the different pathways, testing the reflexes like sensitivity to CO2 and hypoxia. We can also investigate the cellular level, which we've already began a little bit. There's evidence that some of these SCN8A mice have elevated parasympathetic activity, and I've found that in one of our mice we have elevated activity of these parasympathetic neurons in the brainstem, which could explain that. And finally, I'm going to be recording these mice 24 hours a day, and we can get this data showing their heart and breathing activity maybe to produce biomarkers that could predict when SUDEP-like events will occur. So with that, I'd like to acknowledge members of the Patel Lab, our collaborators, and to thank all of you for your attention, and glad to take any questions.
Over there first. So in addition to the question of why does breathing come back, why does breathing stop in some seizures and not others? And I know you probably don't have an answer to that, but do you have a best guess, or what is your hypothesis?
My guess is all to do with the apparent EMG activity. So this tonic flexion of the muscles may include the diaphragm, and if it's contracted, it needs to oscillate to breathe, right? So if it's contracted that whole time, you're basically just like falling into cold water, holding your breath. And so that's my guess. And whatever, there's, I guess, a number of things that could be driving that, but yeah.
For those of you who were at the Dravet Syndrome Foundation meeting last night, Dr. Richardson showed the same, seems to me, the same pattern that we just showed. Can you guys get into dialogue about, do you agree that both the SCN8A and 8A models show the same thing?
That's right. We spoke today. I'd say from our conversation there are some differences, but they're slight. Mostly we're in agreement. Yeah.
Okay, I'm a parent, not a researcher. So forgive me if this is like a really dumb question, but I'm wondering if in your mouse models or anyone who's doing these kinds of studies, is it ever something you would do if you're tracking and watching this apneic seizure happen where you would start to try to intervene to see if there's a way to get the diaphragm moving again or anything like that?
In Dr. Richardson's study they published this year, right? They found that there was apnea in a Dravet model, and they did resuscitation of the breathing. They ventilated the animals, and that was enough to recover them when normally they could not. Yes. So with that one, they were able to induce the seizures, and so they were able to be right there. These are going 24 hours, and sometimes you can see it was dark, so I'm not there. But that would be something to try for sure.
Have you seen any differences in post-ictal generalized EEG suppression in seizures with apnea versus those without?
So I think in the one that I showed here, I'm going to say that I haven't looked at that closely. But I'd say in this one that you look at here, there isn't a large difference, I don't think. I got to go. I got too many clicks here. So I think, if you look at this suppression versus the suppression, it's the same animal, it's the same headset. I haven't changed anything. I think it's not that different. Yeah.
For the next speaker.
Please welcome Dr. Jennifer Wong.
Thank you. I wanted to first thank the Acute Syndrome Foundation for the invitation to present some of my work today. Tonight I'm going to tell you a little bit about the SCN8A R1620L mutation in a SCN8A mouse model. So the R1620L mutation was identified in a proband with autism, but without a reported history of epilepsy. This mutation is a de novo mutation, and it's found in the fourth segment of the fourth transmembrane domain. And so in Dr. Andrew Tickle's laboratory, we're interested in studying the spectrum of clinical phenotypes in patients with SCN8A mutations. And so we picked this mutation because the patient had behavioral abnormalities but without seizures. So using CRISPR, we knocked in the human R1620L mutation into the mouse SCN8A gene. The first thing we did was to look at survival of these mice. And so what we see here, the males on the left and females on the right. So the mice developed normally until about P15, postnatal day 15. But the homozygous mice start to lose weight around that time. And so what we also see is that the homozygous mutants die by about P22. But interestingly, the heterozygous mutants develop normally, but we do have about 80% survival by P60. And so one of the first things we wanted to look at was the seizure phenotype in these mice, although the patient did not have seizures that we know of. So we first looked at susceptibility to several different induced seizures. So the first one we looked at was using the 6 Hertz seizure induction paradigm. So this is an electroconvulsive paradigm. So we stimulate the mouse through the cornea and we observe for a behavioral seizure response. So if a score of 0, the mouse is normal and walks away. A 1, the mouse is immobile for a couple seconds. 2, the mouse is rearing back and paw waving. And 3, the mouse exhibits a generalized tonic-clonic seizure with loss of posture. So in this diagram, each circle represents a mouse. And so what we see here is that our heterozygous mutants have class 2 and class 3 seizures, whereas the wild-type litter mice do not seize. So this demonstrates that the mutants are susceptible to 6 Hertz induced seizures. So we next looked at the chemiconvulsant fluorothil. So this fluorothil is dripped into a chamber, and the mouse inhales it. And so you measure the latency to 2 seizure events, the first myoclonic jerk and the first generalized tonic-clonic seizure. So in both of these cases, the mutants shown in red have a decreased latency to the first jerk and to the first generalized tonic-clonic seizure compared to the wild-type littermates, demonstrating that these mice are susceptible to fluorothil. So we've tested a number of different seizure induction paradigms. So these mice, the heterozygous mutants, are susceptible to several different paradigms. We've also, I'm not going to show you today, but I've also done a month of continuous EEGs on these mice, and they do exhibit spontaneous seizures as well. So one of the things we're interested in to see if we could test different compounds to protect against these seizures. So I've previously shown that huperzine A, which is a reversible acetylcholine esterase inhibitor, is protective in mouse models, or in SCN8A mouse models. So for that reason, I wanted to test to see if HUPE could also protect against induced seizures in these mice. So using the same 6 Hertz induction paradigm, I tested to see whether HUPE was efficacious. And we see here in the wild types, so the vehicle-treated wild types did not seize as expected. And then the HUPE-treated wild types also did not seize, demonstrating that it didn't make things worse. And then over here in the red, we see that the HUPE-treated mutants were completely protected from 6 Hertz induced seizures compared to the vehicle. So this demonstrates that HUPE may be efficacious in these mice. So we also tested the effects of HUPE in another seizure induction paradigm using the chemiconvulsant pentyletetrazole, PTZ. And so we measure the latency to the first generalized tonic-clonic seizure. So over here on the left, we see that regardless of genotype, the HUPE-treated wild types and mutants all exhibited an increased latency to the first seizure, demonstrating that it is increasing resistance. Another way to look at it is to look at the percent of mice reaching a generalized tonic-clonic seizure. And we see that over half of the mutants that got HUPE didn't actually have a seizure. So this is really exciting, demonstrating that HUPE may also be efficacious in SCN8A-derived epilepsy. So in addition to the seizure phenotype in these mice, we were also interested in studying the behavioral phenotype since the patient had autism. So the first thing we did was to look at locomotor activity, or just normal activity using the open field paradigm. So in this paradigm, you place the mouse into the center of the box and you observe and measure the distance traveled and speed and the time in the center of the box. And so what we can see here in the red dots, the mutants traveled a lot farther and a lot faster compared to the wild type littermates, demonstrating that these mice are hyperactive. And since the patient had autism, we were interested in looking at different aspects of social behavior. And so we used the 3-chambered social interaction apparatus. So in this apparatus, there's 3 chambers, like the name suggests. In the first 10 minutes, we had 2 empty wire cages in the chamber, and then you let the mouse explore. And then in the second 10 minutes, you introduce a new mouse into one of the wire cages, and you measure the time exploring the empty cage or the new mouse. So over here on the left, you can see that both the wild type and the mutants prefer interacting with the mouse than an empty cage, so they have normal sociability. But when you introduce another mouse into the previously empty cage, so now you have a new mouse and an old mouse, so the wild types here preferred interacting, they preferred interacting with the new mouse compared to the old mouse. But if you look at the mutants, there's no difference in the time spent exploring the new and old mouse. So these mutants have impaired social discrimination. So another aspect of behavior that we were interested in was looking at learning and memory. So we chose to look at the novel object recognition paradigm. So this paradigm takes 4 days. So on day 1, it's an open field paradigm. You let the mouse explore. Days 2 and 3, you introduce 2 identical objects, let the mouse explore. And then on day 4, you swap out one of the old objects for a new object. And you measure the time exploring the new and the old object. So if you look here in the wild types, in the black bar, the wild types preferred exploring the new object compared to the old object. But if you look over here, the mutants actually could not tell the difference between the new object and the old object, demonstrating that they have impaired object recognition memory. So I actually conducted a whole slew of behavioral assessments. And the most prominent behavioral phenotypes were that these mice were hyperactive, they had impaired social behavior, and they also had impaired learning and memory. So today I told you a little bit about our new SCN8A mouse model. This mouse model it's exciting because we can study SCN8A in epilepsy and autism. So these mice are seizure susceptible, they have spontaneous seizures, they have a range of behavioral abnormalities. And what's really exciting is that we've shown that huperzine A may be efficacious in these mice. And I'm really interested in following up in looking at the role of hupe in spontaneous seizures and also the behavioral abnormalities in these mice. That was my acknowledgement slide. So I wanted to thank everybody for your attention and for the Sky Laboratory, and especially Jackie, the awesome undergrad that helped me score a lot of these EEGs and behavior. With that, I'll take any questions.
Very nice. Could you tell us a little more about this compound,
Cupra-DNA is a reversible acetylcholinesterase inhibitor. It's been previously used in China to treat Alzheimer's disease. I previously showed about 2 years ago that it protected against induced seizures in our mouse model of Dravet and GES+. It's not FDA approved for epilepsy, but it just got orphan drug status for Dravet. So this is exciting because I guess we might be able to use this for SCN8A derived epilepsy.
Any more questions?
Thank you. Great talk. I may have missed this, but did you describe the electrophysiological characterization of the mutant, in terms of gain of function? How has that been previously described in the literature?
It's not been previously described. It's currently being evaluated, so I can't say which way it's going to be. My guess, based off like the N1768D, it's likely a gain of function, and especially since these mice have seizures and are seizure susceptible.
Did you say that? Do they die of SUDA, the mice?
So on the EEGs, I've never witnessed a death from a seizure. But these mice, based on the survival, I did, I guess, see death in the home cages, but I can't say why they died.
That was a nice talk. So you said the gating defects are being explored. Are they being explored in the human channel or in the mouse channel? Because the differences that you see in the phenotype would be interesting to see.
They're looking at
both.
it in our mouse.
They're looking at it in the mouse. Be interesting also to see in the human, expressed in the human, to see if there's anything difference between, explaining the differences that you see in the human patient and the mouse model.
Mm-hmm.
Okay. One question. I'm on my way. Hold on.
Yes. So one last follow-up question also about the patient phenotype, because you were saying, I think in the beginning, that the patient does not have a seizure, right, with this mutation?
Not that we know of. It's been challenging getting any clinical information. So in the publication, there wasn't any diagnosis or history of seizures or epilepsy.
Okay.
I can't say for sure if at this point if the proband has epilepsy or not.
Okay. So that would sort of imply that it's a bit of a different effect maybe in this mutation in those patients than compared to other patients. So I was wondering if you looked at other mice or if that's I think also sort of interesting together with this electrophysiological parameters. They are different. And, can you comment on that?
There's definitely lots of differences, I guess, between all the different mutations. There's only a few mouse models out there, so I'm sure we're still learning more about the effects of different mutations on seizures or electrophysiological differences. So I'm sure we'll learn more in the future.
Thank you, Jennifer.
Please welcome to the stage Dr. Kieran Reddy. You skipped the stairs.
I missed there were stairs. Very excited to be here. Kieran Reddy, I'm the CEO of Praxis. It's our great honor to participate in this meeting for the second year. I just wanted to, before launching into the discussion of Praxis and specifically our molecule Prax 330, I wanted to acknowledge the Acute Syndrome Foundation, both Hillary, Julianne, who couldn't be here, certainly all the volunteers. It's an impressive undertaking to put this group of people together, scientists, clinicians, families, And so, having tried to organize meetings myself, I don't think I could have done what you've done. Again, very impressive. These are the types of meetings that we need to make a difference in trying to find new therapies for difficult diseases like SCN8A. But hopefully, you'll see I've been impressed with the discussions today and the talks today, and hopefully all of you will come away with some hope on what could be done for new therapies for SCN8A. So in terms of what Praxis is up to, so we're a small biotech company based in Boston, 2 years old. The company is trying to develop new therapies for treating genetically defined childhood epilepsies like SCN8A. And one of the molecules that we are developing is a molecule that we call Prax-330. And I'll tell you more about the molecule right now and how we're looking to develop it. The molecule Prax-330, which you heard a little bit about in some earlier discussions, is a highly potent, persistent sodium channel blocker. The molecule has some really interesting profiles, both in terms of its in vitro, which is the cell-based properties of the molecule, what it does on the channel, as well as some very exciting data in animal models. So to highlight a few, I'll apologize if some of this certainly is technical. It is a selective blocker of sodium channels, and there are certainly many other ion channels that may have an important role in epilepsy and in non-epilepsy symptoms, but this molecule is very specific for sodium channels. In addition to it being specific for sodium channels, it actually selectively blocks persistent current, and I think you've also heard from earlier talks, that those are those tails of increased leaky sodium that is occurring through channels in neurons, and that in SCN8A may be a component of the cause of seizures and perhaps some of the other manifestations of the disease. One of the other interesting properties of the molecules is its binding kinetics, so it works fairly rapidly in terms of its block, and I'll show you some data on that shortly. We also have some interesting data around how it modulates excitatory and inhibitory tone and balance. Don't have this data in this existing slide deck, but we actually also have some interesting data to support that this molecule Prax-330 can inhibit resurgent current in addition to persistent current, which may be relevant for certain mutations that SCN8A children may have. And then I'll show you some of the in vivo data that we have that the community really has generated. We've benefited from great collaborations with a number of labs that have generated some exciting in vivo animal data with this molecule. And so some background, and I'll go through this. I won't take too much time because appreciating that some of this has been described in talks earlier and also throughout discussions prior to this meeting. There are gain-of-function mutations, in NAV1.6, SCN8A. The protein is NAV1.6. The gene is SCN8A. I have to repeat that myself sometimes just so that I don't forget. And there are also gain-of-function mutations in NAV1.2, SCN2A, which you may be familiar with, of children with SCN2A epilepsies, and those are also gain-of-function mutations that can have also an increased persistent sodium current. So here, here's a depiction of a sodium channel, and then an incomplete closure of a sodium channel could result in this. Let's see if the pointer is the top. Okay. Great. Right, and so here is the persistent sodium current that's been again highlighted by other speakers. So we believe that this pathologic persistent current may be important may have an important role in both the seizures and potentially the non-seizure phenotypes of SCN8A and also SCN2A. We have been generating quite a bit of data through collaborations around understanding the properties of this molecule in vitro, and I've described this at a high level. PRAX-330 is a potent persistent sodium current blocker. You can see that in this left-hand panel here. In terms of its selectivity on persistent current, it's fairly potent. And if you look at it in comparison to some of the commonly used sodium channel blockers like phenytoin, carbamazepine, lamotrigine, lacosamide, you see a much greater selectivity on persistent current. So that's one of the key elements of differentiation of PRAX-330 from other sodium channel blockers. This panel on the right, speaks to its selectivity over persistent current compared to peak sodium current, which we believe is important from a safety profile. Finally, the molecule is not selective for NAV 1.6 per se. It inhibits persistent current across all isoforms of sodium channels, which is why we're exploring this molecule not just in SCN8A, but also in SCN2A, where there's also gain of function in sodium channels that result in persistent current increases. And then finally, here's a table on the lower right hand that shows you some of how PRAX-330 compares to existing sodium channel blockers with regard to its relative selectivity on peak versus persistent block. The other element and characteristic of the molecule that we think is pretty interesting is its relatively fast binding kinetics. And here you can I'll move through this actually fairly quickly. In terms of the technical elements of how these studies were actually performed, but what you can see when you look at a use-dependent block assay, you can see how PRAX-330 has a fairly rapid onset of binding kinetics, and as that compares to other sodium channel blockers. And the same is and here's a bar graph that sort of depicts some of the same information around PRAX-330's relative speed of onset compared to other sodium channel blockers. Finally, finally on the in vitro side, you've seen some data from other scientists on how mutations in SCN8A can result in increased persistent current. Here is a specific mutation, the N1768D mutation, where you see an increase in persistent current. That's depicted here on this trace, as well as persistent current increase here, while there's no significant increase in peak sodium current. And then the effect of PRAX-330 to decrease that persistent current is marked in this study. And we've now expanded this across additional mutants in collaboration with Dr. Patel. The other element of the data that's gotten us pretty excited about the molecule is the efficacy we've seen in vivo models. That is one of the nice elements in the SCN8A space, is we have very while we always are looking for better animal models, I can say that it's actually pretty mature state in terms of the number of animal models that do exist, the different mutants, and how you see both seizures and survival decreases with certain mutants. So with PRAX-330, this was previously published coming from the Jennifer Kearney lab. We've seen efficacy with PRAX-330 in reducing both seizures, which isn't described here, and also mortality, which is described here. So we've seen, as long as the drug is administered to this particular mutant, you're able to see 100% survival. It's only when the drug is withdrawn that you see the animal starting to return to their previous mortality curve. We've also seen similar data with a mutation in SCN8A, and that is why we're exploring this more broadly in addition to 8A. We've also generated some data in some of the more standard seizure models. You may have come across some of these models as well. These are maximal electrical shock, PTZ, 6 Hertz. These were the gold standard and epilepsy models that have been used to develop many of the existing anti-epileptic drugs that we have. And it gives us some sense of how and whether Prax 330 might be relevant more broadly in epilepsies beyond epilepsies that may be driven by increases in persistent sodium current. And based on this data, we do believe that the drug might have a potential utility even beyond and into broader epilepsy conditions. So we at the Praxis team have been working pretty hard over the last year in terms of taking a molecule from animal testing now through human testing. Many of you may be aware to varying degrees on how drugs are developed in terms of what's required. So we've now been able to take a molecule that had some very interesting data in preclinical animal models. We've done what are safety testing in animals that's required for human testing. So that has now been completed to enable human testing. And we're now in the midst of doing phase 1 work with this molecule in healthy volunteers. To date, we've seen that the molecule is very well tolerated, up to 10 milligrams. We're able to see that the molecule is fairly quickly absorbed orally. So this drug is given orally to healthy volunteers. A pretty robust half-life that enables us to predict that this should be at least a once-daily dose drug. And we are excited about the continued development of this molecule. We're moving forward and continuing the safety testing in healthy volunteers. We're also doing what is important in terms of the safety testing before you can go into pediatric populations. One thing that many of you may not be aware of is that before you're able to do testing of molecules in children, you need to demonstrate safety in juvenile animals, and so that is an activity that is ongoing at Praxis as well. So that through the completion of our healthy volunteer study and work in juvenile animals, we'll then be able to study this drug further. So I just to briefly summarize, Prax 330 has demonstrated some pretty exciting data both in vitro and in vivo models. We're now in phase 1 healthy volunteer testing and looking to move the molecule forward into epilepsy patients in the near future. I did want to close on some points related to how do we as a community develop drugs for genetically defined pediatric epilepsies. How will we find good new treatments for SCN8A epileptic encephalopathies? And this is a discussion that's happening throughout this conference, the American Epilepsy Society conference at multiple family groups. What I can say is that this community should be pretty excited about what already exists. To start, many times we just want to understand how does the gene even work? How does the protein work? What is its function? What is its role in neurons? And I think we have a pretty good understanding of what NAV 1.6 does in terms of its activity in neurons and how overactivation of a channel like 1.6 can result in seizures. Still need to understand somehow that gene and how gain of function in NAV 1.6 results in some of the motor symptoms and the behavior and cognition symptoms, but certainly that work is happening in the community. We need good animal models to be able to develop new therapies, and that I think is also something that is a very positive element of where we are in the state of SCN8A, both in vitro models, iPSC-derived neurons. We heard some great work presented at this discussion already. Multiple animal models, rodent models, hopefully soon zebrafish. All of those things are going to be critical for our ability to evaluate new compounds and new mechanisms. And I'll end with this with something that I think is truly vital to our ability as a community to find new therapies for SCN8A, and that is understanding the natural history of these of SCN8A. Certainly, there's been some wonderful work done in Arizona by Michael Hammer's group. Dr. Schneider's efforts as well will be very important as we look to understand how do seizures develop over time in children and patients with SCN8A. How do the other symptoms develop over time with regard to the movement disorders, the behavioral symptoms, in order to be able to do good clinical trials and test new molecules. We need to be able to understand this pretty well. Typically, drug trials are the first trials are in the 3-month range. And so the question is, in a 3-month study, what can you understand? Can you show that a molecule reduces seizures? Can you show that it improves behavior, cognition, movement disorders? And until we have a good understanding of what is the baseline, what's happening amongst the SCN8A patients today, it's hard to know when we give a drug, is it having an effect? And that's something that we at Praxis are very interested in and hopeful to be involved in helping this community move forward with a more continued evaluation of natural history studies, registries, to be able to expand our information and our knowledge on how to do clinical trials. And I think what hopefully is hopeful in this community is, whether it's Praxis or other companies that are developing drugs, it seems like there's a lot of activity and new molecules moving forward. And the important point is to be ready to be able to understand, well, which of these drugs are helping SCN8A patients in which ways, and that is something that over the next few years, I think that's a challenge that I guess I offer to this community, is to focus on this last point, as it will truly make a difference in our ability to find new therapies for SCN8A. I'll just end with again, thank you for and thank you for the several members of the Praxis team that hopefully many of you can meet. We're really pleased to be here. The family's effort to come here to participate is extremely meaningful to us. We derive a lot of energy and inspiration in trying to move all of our efforts forward from you. And while many of you are not scientists or clinicians, your input and your interaction with us is so critical for our abilities to move these projects forward. So thank you very much. I look forward to interacting with many of you through this evening and onwards as Praxis looks to try to develop new therapies for SCN8A. Thank you again.
I know this is it's difficult to predict the future, but could I ask you, if everything went well, if your juvenile toxicity in the animals went well, what timeline are we looking at before this compound might get to patients?
You're gonna ask me. So a prelude will be also a clinician, by training, and I'm very sensitive to being, to not wanting to have sort of false hopes around timelines and to say, well, we're going to have a drug ready by this year or that year, and not, and sort of be deflating to the community in some way. So I think part of my reticence in answering the question is, we don't want to disappoint. We want to do the right things to evaluate the safety of Prax 330 to make sure that it's ready for patients and ready for children for SCN8A. We're going to work with the FDA with the EMA to make sure that, the molecule will be ready for testing when we have the right data sets. So, so we're working as hard as possible to move it as fast as possible, but do that in the most, in the safe way for patients. So I apologize for my non-answer there. Yeah, it is a very important question, and it's an issue in epilepsy drug development overall. All new epilepsy drugs have to go deal with the fact that they're typically being added on to existing therapies. The way that new drugs are being developed are done to at least avoid some of the properties of the older molecules. So the older molecules, have some they have what are described as drug-drug interaction effects. So Prax 330 and other molecules, newer molecules, typically are designed to avoid drug-drug interactions. That's from what's called a metabolism perspective, like that it won't increase or decrease the levels of another drug. It can't speak to how these drugs might interact synergistically from a biology perspective. So, take for example Prax 330. It is a blocker of sodium channels. How will it interact with a phenytoin, with a oxcarbazepine? These are things that we as a company are studying to try to understand. Well, before we would get into patients that are on a sodium channel blocker like phenytoin and carbamazepine, how would we need to think about the right dose so that we are not, or the right titration of the drug so that we're not not doing any harm to these children.
We would like to welcome Dr. J.P. Johnson, Jr.
All right, thanks a lot. Thanks for having me, and thanks for my cutie. I'm super stoked about that. Continuously amazed at the passion that this whole group exhibits. So today I'm going to talk to you about SCN9A. That's our compound that is just finishing up phase 1. It is, much like the molecule that Kieran just talked about, a potent and selective 1,6 inhibitor. But it has a very different kind of selectivity. So we've taken a different approach to this problem than Praxis has. So I'm going to walk you through what that means. So when we talk about selectivity, we're not talking about selectivity for a certain kind of current, the way Kieran was talking about, but we're talking about selectivity amongst the different sodium channel isoforms. So why would you care to do that? The reason is because there are 9 different sodium channel isoforms, and they all have a different role in the body. For instance, NaV1.5 is really important in cardiac function in the heart. 1.4 is important for your skeletal muscle, your voluntary muscles. These 7, 8, and 9 are important in neurons that are outside of the brain. So from an epilepsy perspective, we're not too concerned about those. They're especially involved in pain. 1.3 is an embryonic channel. It's expressed early in development and goes away during the first year or so of life. So, and that leaves 1.1, 1.2, and 1.6, which are the main channels in the adult brain. So obviously, it's not going to help us out any to block 1.4 and 1.5 in the heart and the muscle. But even within the brain subtypes, we know that if you have a reduction in NAV1.1, like patients who have a loss of function NAV1.1 mutation, you end up with pro-epileptic phenotypes. So that's Dravet syndrome. And that's because those 1.1 channels are most highly expressed in the inhibitory interneurons, which have the role of dampening down excitability in the brain. Right? They're controlling the activity of all the other neurons in the brain. Whereas 1.2 and 1.6 are mostly on excitatory neurons. So by blocking those channels, you should dampen the excitability, and that should help with epilepsy. So our idea is that we want to avoid blocking all these other channels and just focus in on the ones that are most important in epilepsy. So that'd be 1.6 and possibly 1.2. So how do you do that? How do you make a selective drug? It's a very careful sort of trial and error. So you start out with some molecule that has some of the properties that you want. You make a new version. Maybe you move a carbon here, a fluorine there, or take away an oxygen or a nitrogen. And you test it against a bunch of different sodium channels. Here we're typically doing 1.1, 1.2, 1.5, 1.6. And you say, okay, well, is this better or worse than the molecule I started with? And then you do that again about 1,000 or 2 times over the course of a year or two. And that's about 15 chemists working in the lab every day, making new compounds constantly. And then the biologists testing them and feeding back on that process. So after a year or two, you've gotten to the point where you have molecules that have the basic format that you're looking for. That means they're potent, meaning they block 1.6. They have sort of the selectivity profile you're looking for. They hopefully have some activity in rodent models of epilepsy. And then you have to fix all the other problems that are inevitably you find. Some of those might be in vitro signals that suggest that maybe this would have liver toxicity, or that would possible problems with the stability of the molecule. It gets just chewed up by the liver too fast. Or it may be signals that it might have drug-drug interactions. And there's dozens of these assays that you have to optimize for, and those problems are just as challenging as getting the first compounds that have selectivity. So that's another couple thousand compounds, another year or two of dedicated iteration by the chemists. So now you're 2 or 3 years in, and that's when you first get to real toxicology studies. Of course, you have some idea of whether the compound is tolerated before that. You've been working with it in animal models, but that's when you get serious about seeing how well tolerated the molecules are. And that takes about a year to get to the point where you have enough of that animal model data to go into phase 1 human trials. And then the phase 1 human trials take about a year to get through, to figure out that the compound gets on board, it gets in the blood, you have decent levels, that they are stable over a good enough time period, and that it has some safety. And that's kind of where we're at, and that's where Praxis is at right now. We're both at the point where we're trying to figure out the next step, the phase 2, how to really evaluate how good these molecules could be in patients. So as far as the profile of the compound we came up with, SCN8A, it's quite potent. And when I say potent, that means that it takes very low levels of the compound to block the channel. Okay, so for example, this is channel inhibition. At very low concentrations of the drug, you don't have any of the channels blocked. At high concentrations, you have all of the channels blocked. And this is just comparing 901 to some of the drugs that you guys are familiar with, and it is much more potent. Coincidentally, it's almost exactly the same potency as the Praxis compound. I don't know, how that happened, but it does seem to be the case. So, about 100 times more potent than the compounds that are available. But this is the thing that makes our molecule really differentiated from anything else around, which is its selectivity against other channels. So this is the same sort of data I showed you on the last slide. No inhibition here, but full inhibition up here. So with 1,6, it's very potent, so very low levels of the compound are required to block the channel. But with the other sodium channels, all the other sodium channels, it's much weaker. So it takes about 50 nanomolar of 901 to block about half of the 1.6 channels. It takes about 5,000 nanomolar for phenytoin, for the other compounds to other channels to be blocked by 901. Coincidentally, it takes about 5,000 nanomolar for phenytoin to block 1,6 as well. But if you compare that to carbamazepine or phenytoin, you can see that those compounds really don't have any selectivity. They block all the channels at about the same potency. So what that means is that with 901, you can block whatever fraction of the 1,6 channels that you need to. So if we need to block every 1,6 channel, we could do that without touching any of the other sodium channels. Whereas if you try that with phenytoin, you block about half the 1,6 channels, and you end up blocking about half of all the other channels. So we don't really want to block all of your 1,6 channels. That would be disastrous because you need 1,6. It's important. But it does mean that we can block, the 10 or 20% of the channels that we think we need to without having an impact on any of the other channels. And it's expected that some of the challenges of those older molecules have to do with the blocking of channels outside of 1,6. And again, as 1.1 block, you would think would be counteractive to your purpose. So we've tested this in a couple of different kinds of animal models. I'm not going to go through them in real detail, but this is one that's based on Shay's mutation that Jc and Miriam made this mouse model. And what we do is just give the mouse a very mild shock. So it's a shock that a normal mouse, a healthy mouse, would just shrug off and not notice. But with these mice, they have a pronounced, robust seizure. And that's kind of indicated here by this high score on this scale here. If you give the animals no drug, they have this robust seizure score. And as you give them more compound and the levels go up, you can inhibit those seizures. Now, you can see that with the traditional compounds, you can also inhibit those seizures, but it takes a lot more drug on board, so you have to have higher levels in order to get that effect. We've looked at also at MES models. So these are in healthy mice that you just give a much larger shock to induce a seizure that even a wild type mouse will have a seizure after a larger shock. And what you can see is that the drug levels or the compound levels that are required to reverse that in the wild type animals is similar to what it took in the other assay. The nice thing about this MES is that it has a strong history of predicting efficacy in the clinic, and so that's a reassuring thing to have on your side. And then if you start to look at what we think the selectivity is going to bias, what we think it will bias is safety. So you can imagine that everybody knows that if your drug levels get too high, you have problems. And what this is looking at here, we'll just say for phenytoin, for example, is that in this MES mouse model, as you increase the levels of drug in the plasma of the mouse, you get suppression of those seizures. And But when you get to around this dotted line level, the mice get just clearly sick. You can see that the mice are not healthy and they're not happy anymore. Okay, and the same idea happens here with carbamazepine and lacosamide. So if you look at kind of how much does it take to start to suppress these seizures, and then look at how far away is this dotted line where the mice get sick, it's not that far really for phenytoin and carbamazepine. So a little bit better separation with lacosamide, but then 901 has this pretty big gap here. So it takes about 100-fold higher levels than where you're suppressing these seizures before you start to get into the stage where the mice are sick. And so hopefully that is telling us that this is going to be a much better tolerated compound in the clinic. And this is just kind of a bar graph that tells that same story. You know, a couple of fold safety margin there for carbamazepine and phenytoin. A bit better for lacosamide, but then 901 seems to stand out above those considerably. So we have started our phase 1 trials, actually just wrapping up our phase 1 trials. And you can see that we're getting nice dose-dependent increases in exposure. And the half-life of the compound is nice, about 8 to 11 hours. So that should be consistent with once a day or twice a day dosing of the compounds. It's actually very different in mice. It's cleared very fast in mice, so you can dose them at breakfast, but by lunch there's no compound in a mouse. And that's because mouse livers are just really keen on destroying this stuff in a way that human livers are not. And so far it's been really well tolerated. We haven't really seen any clear toxicity associated with this compound, which is what we would expect based on the animals, but you know, you never know things until you see them in people. So just going back to this comparison to give you an idea of what kind of levels we've achieved in the phase 1 study. So of course, I forgot to mention this in the first slide, but these shaded regions for the other compounds correspond to about the plasma levels that are seen in patients that are efficacious. So you can get some idea that somewhere around the middle to the bottom of this curve is where you expect to need to be on this in this animal model in order to get efficacy in the clinic. And if you extrapolate that to 901, hopefully we should be already in our phase 1 trial at exposure plasma levels that should confer some good seizure protection, assuming that the mice are really telling us the real story. So just to wrap it up, 1,6 is really nicely potent and it's really selective. There's really not any other compounds that have this sort of selectivity amongst sodium channel isoforms. So we hope that that's going to translate into a really differentiated compound as far as safety margins. It has good PK, and so far it's been well tolerated in humans. And of course, the next steps are to see if this thing really works and to put it into some patients and to see whether we get some efficacy. Right now, we're talking about exactly how to do that, whether this is going to be in adult patients, whether it's going to be in pediatric, genetically defined populations, and that's going to involve talking to the FDA and some back and forth discussions and some careful planning. But we're hoping to get that initiated as soon as possible. We do, and I haven't talked about this at all today, but we have another totally separate program on KCNQ2/3 activators. So these are potassium channel activators, which we hope will be useful. And we're starting a phase 2 trial in adults very soon for that compound, SCN1101. And there is a chance that this could be useful as well for SCN8A patients. Theoretically, it makes a lot of sense because KCNQ2 channels work in opposition with SCN8A or NAV1.6 channels. And so activating potassium channels might actually turn out to be an effective strategy for this population as well. It takes a big team to make a new compound like this, and these are most of the people, but I would probably say probably not all of them. The people in blue are not necessarily the most important, but they are here at the meeting, and so I wanted to highlight their names so that you can hunt them out and if you have questions for them. And of course, we also rely a lot on the insights of the academics here, and you know, really the key insights that they have into the biology of the disease are really what enable us to pursue practical approaches to addressing the disease. Quick point that we do have 6 posters here at the meeting, so for people who are going to the meeting, feel free to stop by. Some of those are about the potassium channel opener, and some of them are about 901. And I'll wrap it up with that.
So why not go after both NAV 1.2 and NAV 1.6? Do you think that would cause more side effects?
So it's a good question. It's a question we've asked ourselves a lot. Initially, going into this, we were sort of agnostic about NAV 1.2. We said, we definitely want to hit 1.6, and maybe we want to hit 1.2. We imagine that hitting 1.2 should have some added efficacy, but we also assume that it may bring with it some extra side effect risk. But as the chemistry evolved, we ended up with two groups of molecules. They diverged, and we had some molecules which are, like 901, really selective for 1.6. And we have another set of compounds that actually is dual active. So they hit NAV 1.2 and NAV 1.6 more or less equally, but still spare all the other channels. So we're really interested in digging into those to see whether they can have an added benefit as well.
Great talk. I was just wondering if you had tried your KCNQ23 activators on the 1.6 mice.
We have not. It's certainly something we have thought about, but we haven't gone there yet.
So JP, you and I have talked about this before, but for all the parents in the room while we're waiting for your compound and Praxis compound to come out, somebody might get the idea they should go try lacosamine based on what you showed. Lacosamide. Vimpat. Do you have any further thoughts? You thought that there was something unusual about it, and it sure looked like it on your charts there, that it was doing something a little different, but it had better toxicology or profile.
Yeah, it's something that we've talked about a lot in our program. It does feel a little bit like lacosamide is doing something a bit different than the other sodium channel blockers. Its profile is just not quite consistent. So personally, I have a tendency to think that there's some other pathway involved besides just sodium channel block with that compound, but we don't really have a good answer for that.
Are there any more questions? So we have a little bit of time left over now for just a general discussion. So if anybody wants to start off, they can. And if not, I had a comment I wanted, or a question I had, and that was going back to the SUDEP mouse respiratory data that Ian had shown, and I think Dr. Richardson has left. But so my understanding was that some of the parents actually have apnea monitors that monitor the children when they're sleeping. And so if your child is having tonic, because it seems like it's when in our mice models, it's when they have this tonic seizure, when they're very rigid and stiff, is when they have these apnea episodes of apnea. So as a clinician, is this something that you tell the parents, that, or is it something that you look for, or is that something we just see in mice, or are you seeing it in humans as well?
So, people have looked at doing either pulse ox or monitoring for apnea. I think the most useful thing probably is just monitoring for seizures, and that's what I recommend to my patients, is that they monitor for seizures, whether with some kind of direct monitoring, whether with a baby monitor, or now there's several devices that are out there that they each have their own benefits and drawbacks, but I think that's probably the most effective thing. So you identify the seizure, and then there's actually some evidence to show that actually helping someone wake up or intervening can help to reduce that apnea and interrupt that. Anyone else have thoughts? Yeah.
So along those lines, I feel like I get a different answer from every doctor I talk to, particularly neurologists, on the current, no offense, just like on the current general consensus on, do we need to administer oxygen? Does that actually help? Is it just to make the parents feel better about themselves? Like, why? My doctor personally tells us don't worry about it and don't have oxygen at home. But I know the rest of the parents, most of them do have oxygen. I'm just wondering, does it actually do anything? I don't know what to do with that.
So I think there's no consensus on this. It's been a question. It's been debated, but as far as I'm aware, there is no consensus on this. And it's related to the apnea, but a bit of a separate issue anyway. If any other clinicians have any thoughts on this, I'll let them speak up. I have prescribed it from time to time in kids who have demonstrated significant hypoxia with seizures. Oh, yeah, well, yeah, right. So, but it depends on the degree of cyanosis, turning blue, whether there's perioral around the mouth. There's a kid who really is just turning dark and dusky and blue all over, and that's obviously more significant. So in those cases, I have, but I don't know. Yeah.
I think it's definitely easier in the mice model to look at these things, and it doesn't translate that well. But it was a question that I've always thought about. So are there any other questions from the research, the physicians? There's one over there.
Thank you. I just wanted to ask a question of Jc Wagon. So just a methodological question. What is the usefulness of tamoxifen to activate the gene defect? And how does that work, actually?
So the molecule that actually is activating the gene is a Cre recombinase. So it binds to the DNA and takes out that exon I was talking about. And how those are expressed or when they come on is based on their promoter that they have. So they can be specific for a different part of the brain, or in the case of the tamoxifen, it's timing. So the promoter is an estrogen receptor analog. Normally the estrogen receptor responds to estrogen, but in this case it's going to respond to the tamoxifen, which is an analog of estrogen. And when that binds to the estrogen receptor, it takes it to the nucleus. So it takes that protein, that Cre, to the nucleus where the DNA is, and then it can chop the DNA out. But it won't go there until you give it the tamoxifen. So before that, it's not in the nucleus, and it can't access the DNA. So it can't activate our mutation. Does that answer your question? Okay.
Are there any more questions or comments? I guess I would have one for the researchers for next year, and that is, we saw a lot of work today with mice models and iPSCs, and we've seen electrophysiology, and we've seen some translational work as well. So is there something that none of us are actually looking at or doing? I mean, we've looked at different areas of the brain. Are there techniques that we should be looking at to explore networks or different areas of the brainstem? I mean, is there something that we feel that we might be missing, and perhaps there are certain people here who could start to look at those areas in these mice or in these iPSCs? It's a big question, I know, but I feel like perhaps there are some areas that we're not quite looking at yet. Maybe we could recruit people into the field that are experts in those areas and to answer some of those questions. But that's something I think we should think about. Perhaps next year, you know, we've got plenty of time to think about it. We could talk a little bit more about what areas are missing for us as a group for SCN8A.
I can only offer a clinical observation, but it ties into something Michael just said. I wonder if there could be some more work on differentiating the different sodium channel blockers. Just an observation is I've had some SCN8A patients who respond quite well to phenytoin, better than anything else, but others respond much better to lacosamide than not anything else. So, I can't tell you which variant is best, but there's some differential effect in these patients with the different sodium channel blockers. There's something going on there.
So I think JP is here. I know that you folks have done some work with the different blockers. Do you want to comment on that, or do you want to?
Sure. I think that there's still a lot we don't know about this. I mean, I think there are many ways in which these compounds are different from each other. Kieran pointed out, that there's differences in kinetics, which have potentially have big impact on how they equilibrate with the channel. And phenytoin, for example, equilibrates with the channel quite slowly. Carbamazepine quite quickly. Lacosamide, as I said, I suspect that, and it's quite slow, and also I think there might be something else going on with that compound. And Ted has done some work on lacosamide suggesting different mechanisms as well. But I think we still have a lot to learn exactly about how the best way is to tweak the channel.
And I'll just add one. Yeah, I'm going to go there and then there. But the different mutations behave differently, right? And so I think that's why it gets very complicated too. But I think an area of research I think we need to get published very quickly is Keppra, levetiracetam. And so if we can get that out and publish, I think that would help pediatric neurologists who see these patients for the first time perhaps won't try it, because it is a very good drug that's used very often in patients with epilepsy. Just going to go here.
I have a question for JP with you trying to target specifically the SCN8A. Are you hoping because, like my son has fairly good seizure control on Dilantin and, the sodium channel blocker, are you expecting to see maybe some developmental achievements if you can just target the one and stop, the other ones affecting the brain? Are you expecting maybe like developmental gains by, specifically just targeting just the one?
That's a great question.
It's certainly our hope. We won't know until we give it a shot, but the hope is that by having a cleaner compound that really just goes after the one channel, that we will reduce all the kind of effects that are not directly contributing to the efficacy, and so that will allow us to have a compound that's just much better tolerated, and possibly even to allow for more block of the 1/6, to really dial in exactly the amount we need. But until you see it in patients, you just don't know.
Well, I guess just two comments for both of your questions. So one is, I don't know how many of the parents are familiar with Dravet. Okay, so that's where you lack 1.1, and they cannot tolerate sodium channel blockers, presumably because they can't tolerate any more loss of 1.1 already. So what JP was talking about was something that doesn't block 1.1 at all, and the assumption is that that's countervailing the efficacy that you would get from 1.6. So fewer side effects, an opportunity to get more block. In terms of your question, I suspect that, if you're in, let's say, for example, we talk about all gain of function mutations as being the same, and they're not, right? Okay, and then, so what we don't know yet, and where a registry would help, is to get a better understanding of how each of the mutations affects the channel, and then which which compound works most effectively. I think there's a tremendous amount that you could do with the, with the registry.
Thank you. Just a comment about the Keppra as well. I always kind of thought it might have been just because that's the first medication that people are placed on when they have epilepsy. And you're going to see a clinical worsening naturally anyway. But looking at a lot of these kids, that doesn't seem to be the case. Even if they were on another medication first, they get put on Keppra later on. You really do see the same kind of thing for a lot of these kids. Yet there's a couple here and there that actually do seem to respond favorably to it. And I think we can learn a lot from those kinds of outliers. So I think really focusing in on those cases as well that seem different. There's something different about those cases. And trying to understand why that is, whether it's through more careful clinical testing, EEG, functional assays, I think it could be really informative. And then also, knowing what's loss of function and what's gain of function is also really important to patient selection for trials and just understanding more about this also. That's the other comment I would make. And then the question I had, I guess, is what other kinds of secondary outcome measures we might want to look at. One thing I was struck by at the Dravet syndrome meeting last night was one of the secondary outcome measures they looked at was a behavioral rating scale. And I think it was the only time I can recall seeing a negative placebo effect and a clear response within a short period of time to the medication. And I think that's a kind of thing that you probably could see a change in over a 3-month span. And we've all seen it where someone does seem to either get worse with the medicine we use or get much better with the medicine we use over a short time span. So any other thoughts on things that we could look at or things we could measure that would change in a 3-month time window?
I'll just add one thing. I mean, in my presentation, we kind of did the analysis very recently, and it was shocking to me to see how many other variants our patients in the registry had other than SCN8A. And so I think one of our goals will be for next year is to really do a much deeper dive into what patients with SCN8 plus do or don't do, like patients who have what we think is just SCN8A, because we lost the keys over there and the lights here, and we keep looking under the light, which is SCN8A, and all the NAV 1.6, but we're forgetting. I know we're not forgetting, but there's the whole genome to consider. And we did a study with Dravet patients who had a more severe form and a more mild form, and when we looked in the exome for variants that might explain that as a modifier, it turned out it was not a single modifier, it was the genetic background the patient was born with, which was just very rare variants at many different loci that are involved in neurotransmission. And we looked at 237 different genes, and variants that were predicted to be pathogenic versus benign were differentially found in the two groups. And so that sort of triggers the idea that we're kind of working in a more complex system in humans, but yet our models are simplified, and they have to be because we won't get funded to study even heterozygous mice. I mean, isn't that true, Miriam, that you put a grant in, you say, I'm going to study a mouse that's outbred, they're going to think you're crazy. But humans are not inbred. So just another thought. So I think the registry can help with that as well in some aspects.
Thank you. So I'm not a clinician, so it's more like a question for clinician. Many parents, or it has been reported in these children, they have problem of swallowing. Is it proper to the mutation or this type of EI13, or do you see that with other childhood epilepsy?
It's a good question. We do see it with other forms of epilepsy as well. I don't know exactly the frequency with which you see it with other types of epileptic encephalopathies, but it is something that we do encounter a lot. One thing that I found striking, though, were that there were children who were able to communicate fairly effectively, yet had significant safety issues with swallowing that were sometimes under-recognized. So I do think that's something that might be more specific to SCN8A-related epilepsy, that you can see dysfunction in swallowing that might be out of proportion to what you would otherwise expect, and that should prompt one to think earlier about getting a swallow evaluation or some kind of assessment to really prevent risk, pneumonia, mortality, those kind of things.
I also in our casuistic, so I think this might have a sense. It's also quite specific. The drooling is early before the thing.
Well, so some do have a swallow study. I'm not sure about the answer to that question.
Just wondering whether any of the mouse models we could try to recapitulate.
Oh, I don't know. Any mice people?
So we're going to finish up now, and we'll just give it back to Hillary for some final words.
Okay. So I just wanted to say thank you all for being here. This gathering is just one of the highlights of my year, and I know it is for a lot of the families who come. And we're so appreciative of our sponsors for making this possible, for our partners from Brazil, and Daniel and his family, and Ayuda Rafa, for coming and running all of our AV. They are absolutely amazing, and we are so lucky to have their help. And I want to thank all of the researchers and clinicians who have come today and shared your knowledge and are showing that you're in the fight with us, and we really appreciate that. I especially want to thank the families who traveled to be here. We know it's not easy, and it's incredibly meaningful. I'd also like to thank our volunteers at the Acute Syndrome. If you could stand up if you volunteer for the Acute Syndrome. Go ahead. We have a truly amazing team, and I said earlier they represent more than 10% of the patient population that we're in touch with. They are doing a lot of heavy lifting and making really amazing things happen that seem to be out of proportion to the size of our community, and I think they have placed us in a position to do amazing things. And of course, I have to thank my co-executive director, Julianne, who can't be here today, for doing a huge amount of work to make this gathering happen. And it's very sad not to have her here with us. Thank you to all of the speakers. And thank you to our wonderful co-chairs for also doing a huge amount of work to make this event happen this year and keep it running. I think the best timing we've done so far, not an hour and a half over. So thank you, everyone. Have a wonderful evening, and thank you for being here. Thank you.